or teamwork, reduce unplanned extubation by 48%. And also this is a systemic review study, shows, out of these 10 studies, 7 out of them shows there is an improvement of unplanned extubation after you improve your qualities issues. And this is also in Cincinnati, where they have a quality project that it's reduced unplanned extubation. When people know, or the culture have been changed, that we should not have any unplanned extubation or anything related to, qualities issues. This one is some of the strategy. Probably I'm in time. I need to go a little bit quick. In addition to that, central lines, early warning score, rapid response. We need to do simulation. We need to do simulation, improving our quality. We need to choose different technology to improve our safeties. And medication errors and issues. We notice in our unit we have more medications error, and mainly was prescribing. So we have an root cause analysis. We study them. We have an educational activities. We talk to our resident. We notice it's the area with more resident, you are going to have more medication error. One of the ICUs being covered by assistant specialists, there was no medication error. So those frontliners, trainees, we need to do a lot of work. We do monthly activities. We discuss any safety issue related to medication, either within the unit or at level of hospital. We were able to reduce medication error. We use a family also. Family, they might tell you, especially those family coming from outside, from home, they are medication, they will tell you, what is this medication? This is new, or this is the time my son or daughter should receive her medication. In addition to that, dashboard is really an important part. It's also have been recommended by Joint Commissions. We use our dashboard. This is a dashboard that's every morning, and it's 24 hours being updated. It tells you where we are. It tells you how much unplanned extubation I had. It tells you how much mortality rate I had. It tells me about medication reconciliation. Is it all the patient medication have been, especially those coming from outside, have been reconciled? Tell me about, self-extubation. Tell me about utilizations of lines. Planned extubation. I need to go to my team, what happened, and then we form a team looking for root cause analysis and looking for why it happens. We didn't look who was involved with that. We're always looking to the system. If there is an issue, usually a system issue rather than a personal issue. Majority of mistakes happen because of system, either shortage of staff, inexperienced staffs, or something is related to communication related to the system. So we find this dashboard tool, and this have been seen by higher administrations, everyone in the hospital leader, they will see, and they will see different units. Anything out of light that there is something wrong. Emergency room, they have the same one. If they have more patients in the waiting area, if they have patient was not seen, if they have patient that decision was to admit but there is no bed in the floor, is going to tell them there is something wrong. If your length of stays have been increased, someone is going, is it because there is no bed? Bed utilization office going to come and help you, trying to create beds for you, so to move your ICU patient over there. As audits, very important. You really need to have, you benchmark your unit. This is a benchmark that we call it a VBS. International data is more than 100 hospitals in North America, Canada, and Middle East, and other places. So it compares us to other international institutions. It has multiple variables and quality indicator. It will tell me, for example, risk of mortality, and it will tell me also about adjusted risk of mortality. And it tells me how much am I doing good or not? Is other places is better than me? And it tells me where shall I work? I have deficiency in that area. Maybe my mortality rate is high. I need to fix it. Or maybe patient compare me my stay of my patient to other patient. Maybe patients stay with me longer that they didn't need it. Maybe I do have an issues in the pediatric or in the general floor that I cannot move patient to them because they are already full. So it's very helpful and indicators, and they have multiple variables of indicator, and every year they give me a report comparing me to 104 hospitals and tell me where is a defect, so I really need to work on it. RRT is really an important. This is one of the study in Jeddah Hospital. It's reduced unplanned extubations, and it will minimize to zero the code. This is one of our study earlier on, before we start rapid response team. Resident, usually we have a code, at least in Department of Pediatric, once every 2 to 3 days. Now probably we have a code once every month. But tell you how much rapid response team culture is a culture, the word culture. People understand that your patient is sick. Moms understand, have been involved in the RRT. She need to call, she need to activate an RRTs. Patient is early rehabs, improving outcome, which is one of the quality issues. Sometimes patients will stay in our unit, intubated or sedated or sick. We didn't move them, we keep them until at the end they come with contraction. So we always need to do better quality improvement project in this one. So to conclude, safety, it will measure how good is your institution. It's not a matter you have a good surgeon or not a good surgeon. You could have the best surgeon in the world, and then he did his surgeries, and then he go to the floor of the ICU and he died. And this is because of safety. In the past, people talk about outcome is how many good physicians you have, how many good nurses you have. Now it's not anymore. Now how much is safe is your hospitals. Safety in medicine should go like safety in aviation. And you could see when you go in the airplane how much safe they are, how much do this, fasten your seatbelt, don't move, don't talk, don't do this, don't do. They have a lot of safety issues. And you know, when the plane land, anyone stand up, what will happen? Jarima, everyone, oh please sit down. So this is what needs to happen. This is what needs to happen in hospitals. We really need to talk about safety. We need to discuss it. We need to change a culture of a safety culture. And it's not an optional, it's a mandate. It's something that you really need to move to on that directions. And safety culture is the backbone of excellence in care. If you are looking for excellency in your center, you should be looking for safety of your center. And a true safety culture means doing the right thing, even if there is no one watching you. There will be a conference in Riyadh, and Euro Riyadh, the collaboration between Society of Critical Care Saudi and Society of Critical Care in Europe. Safety is, we are going to have a lot of panel discussion in regard to safety. November is a good month to visit Riyadh. You are all welcome to come and visit us. And thank you.
وحنان، ونحرص على رعايتهم صحيا منذ البداية وفي كل مرحلة من مراحل نموهم. ونحن معكم دوما نحرص على تقديم رعاية أفضل لهم. الآن أضفنا لهم زيارات متابعة وتقييم في سن 3 و4 سنوات ضمن سجل متابعة صحة الطفل. فلنحرص على متابعتهم من أجل صحة أفضل ومستقبل مشرق.
حضورنا الكريم، قد ها نحن وصلنا إلى نهاية برنامجنا. نتوجه بجزيل الشكر لسعادة الدكتور أحمد بن سامي المنظري وكيل وزارة الصحة للتخطيط والتنظيم الصحي، كما ندعوكم لافتتاح المعرض العلمي لليوم العالمي لسلامة المرضى، فتفضلوا. وكما نتمنى لبقية الحضور البقاء في أماكنهم والاستمتاع بمشاهدة الفيديو، وشكرا لكم.
Mati. Bro, Babu, go to mic. Bro, take a 5 minutes. Yes. Which mic? Sorry, take the one mic. That's it, yes.
big. Okay?
يلا يا جماعة عشان نبدأ. أعزائي الحضور اللي في الخارج لو سمحتوا إذا ممكن ترجعوا إلى أماكنكم عشان نبدأ نكمل إن شاء الله. I will present Dr. Salima. Dr. Salima obtained her MD degree from Sultan Qaboos University, Pediatric Residency Program from OMSB. She has a membership in Royal College of Child Health from UK and Neonatal Fellowship from University of Toronto in Canada. She published in many international journals like New Reviews, the Pediatric Infectious Diseases, American Journal of Neonatology, at the European Journal of Pediatrics. Welcome, Dr. Salima Laisi.
Assalamu alaikum. I would like to thank the organizers for giving me this opportunity. I would like also to thank the colleagues who agreed to give me their time because I have some other commitment. So I will be presenting today about quality improvement projects which we did in the neonatal unit of at Khawla Hospital, along with the neonatal team there. Stuck. This is the project team. The project went through 3 phases. Phase 1 included mainly the neonatal team, and I would like to acknowledge the team leaders or the project leaders who worked with us, Dr. Manoj Malvia, Dr. Mohammed Al-Yahmadi, and Dr. Vidya Ramdas. The second phase of the project, after analyzing the situation, and we had to reform, so it was mainly myself and Dr. Vidya Reno and Mr. Yasser Al-Rahbi, the clinical physicist in the hospital. The third phase, which is ongoing and led by Dr. Mohammed Al-Yahmadi and Dr. Talib Al-Harthi. So the project was mainly about reducing radiation exposure in the extreme preterm babies, and as we know that many of these preterm babies, they have an increased length of stay in the hospital. And because of that, we thought of measuring how the total radiation exposure they get during their stay in the hospital. And why this matter? When we started thinking of this, we looked into the nature, the particular nature of the preterm babies, and they are extremely radiosensitive population. They are exposed to many X-ray studies because of the comorbidities they encounter during their stay. خليهم جنب بعض هذا. You can hear me? Okay, because of the nature of the pathology or the diseases they encounter during their course of admission, they require multiple images. The more extreme prematurity they are, the higher likelihood of having overexposure. So in the extreme preterm, the likelihood of overexposure goes to 2.5. And as their gestational age increases, this comes down. The risk of overexposure depends on the radiation dose, the other characters of this population. So we thought that each NICU need to have a practical safety benchmark where they look into their radiation, the cumulative radiation dose. And we need to know, because usually we request the X-ray or the image, and the radiographer come and goes, and at the end we don't know how many or what is the total cumulative dose these babies are exposed to. And we know that each study increase the risk of the cancer risk. So the goal of this project was safe and necessary and as low as reasonably achievable radiation for these babies. The scope of the study was to focus on those who are vulnerable to repeated images and mainly the preterm babies below 32 weeks. We wanted to evaluate our baseline radiation exposure and to reduce the DAP, the dose area product, as defined, which is defined as the absorbed dose times the area of exposure. We aimed at reducing this by 30% by implementing a radiation optimization protocol. Overall objective was to minimize the total cumulative effective dose, which quantifies risk of long-term cancer or other complication. The benchmark is, unfortunately, we don't have a solid evidence on what is the safe cumulative dose for this population. However, many studies or many benchmark, they are taking the cumulative dose of more than 20 microsieve, which is equivalent to microgyri in the first years of life as a concerning level. So this is the fishbone, which we did at the phase 1 of the study to look at what are the risk factors contributing to these babies exposed to high radiation. And at this stage, we didn't have a measurement or we didn't have numbers for the doses. At that time, our PAC system, the radiology department, they were not reflecting the dose per image in the system. So what we could do at this stage is only counting numbers of X-rays those who stay for a long time are getting during their admission. And we identify the main factors which may contribute to the high exposure dose. And these variables, some of them are not controllable because they are related to the equity of the illness the baby is going through, and you cannot avoid the X-ray, you have to do it anyway. So we focused on those who we can do something about, and you can see that graph shows the number of X-rays a neonate may have during his admission. And you can see that some of them, the X-rays can go up to as high as 40 X-rays per 2 months or 3 months of the hospital stay. So based on this analysis, we decided to have a dose audit and quality control study. And here we went into phase 2 of the study, which we had to involve the radiology and quality department, and we agreed on an intervention bundle. The measurements which we thought we will focus on, طبعا this is like a neonatology driving a project which he is not very familiar with, because we are not expert in radiology, but then we had to do some brainstorming, discussions among the colleagues, and we agreed that these are mainly the parameters which we need to have a quantitative values of DAP, which is the total radiation dose, time exposed area, and it reflects total radiation burden. And in many of these parameters, you will find that even a small increase in the field significantly raise the dose. And we agreed along with the radiographers and radiologists that they need to collimate tightly. Collimation means that when they expose the beam on the baby and they put the cassettes, we use the small cassettes. However, if you increase the collimation, that means that you are increasing the area of exposure, which will lead to more absorption. ESD is the entrance skin dose. Entrance skin dose is a surrogate marker of the total dose the baby will absorb, or in general, the same concepts also applicable for adult. So this is the surrogate marker, which will tell you the total dose the patient will absorb at the end of whatever other parameters you will set. Milliamp per second, this is a product of tube current multiplied by exposure time. And here you think of it as like when you water the plants in your garden and you use a small pipe, then you have a higher speed. You use a bigger pipe, you have a smaller speed. This is a currency or the flow of the X-ray beam. It's a key factor under operated and controlled by the operator, and it has to be balanced to give you a good quality image. One more parameter, ESD is difficult to control when the radiographer sets the parameters in the X-ray machine. So because this is the reflection of all the other parameters. One more parameters we measured, which I forgot to put here, is the KVP. So KVP basically is the speed of the flow. And you need to balance it because high KVP, which will give you a fast-moving beam, although it may affect the quality of the X-ray. However, a low KVP also will give you a more absorption and higher exposure, and it will affect the other parameters. So after sitting with the radiologist, we agreed, and looking for the benchmark, we agreed on what are the targeted values we would like to monitor and we have to be reflected in our X-rays. So the babies who are less than 1 kg, we looked at the benchmark, and most of the benchmark they advise between 50 and 60. Because we had a variability, and as I will show you in the coming slides, we thought we will start with a KVP of 60, and for those who are below 1 kg, and those who are between 1 to 2 kg, we were targeting 65, and those above 2 to 3 kg, 70. And the babies who are above 3 kg, we didn't target KVP specifically. We thought what we wanted to know in the first, in this second phase, what will be the minimal KVP you can take to give you a best quality of image, controlling the other parameters. So we started with standardization of the procedure. We had a protocol which is stick to the mobile X-ray machine, so all radiographer, because we don't have a specific radiographer to the NICU and they rotate and different people come. So to control the human variability, we thought that protocol should be there. We trained, we had a discussion with the nurses because they are the first, or the first helper to the radiographer when he comes, so that they know what are the procedure which it became like policing the radiographer when he comes to the unit. So she will make sure that he's following the protocol which is sticked on the X-ray machine. We agreed on the doses depending on the initial survey which we did. We implemented the radiation stewardship from between the clinician ourselves. We agreed on to eliminate unnecessary repeats. For example, sometimes we have to repeat for PIC line. We have to repeat when the quality of image is not good. So we want to minimize these repeats as much as possible. One of the contributing factor for masked or hidden overexposure was cropping. So the radiographer will come, he will take the image, maybe he has a big cassette, and then he will crop the image. We prohibited that practice fully, and they were very cooperative. Dr. Vidya, who is the project leader in the NICU, she has the access to review all cropping done by the radiographers. And we started dose tracking and monthly feedback, education, and targeting image gently campaign. Ultrasound-based substitute, this is the project, the phase 3 of the project, which Dr. Muhammad and Dr. Talib are working on. That means that we want to validate the consistency or the correlation between ultrasound and X-rays. and X-rays. And almost all our registrars are trained to do bedside ultrasounds. So they do lung ultrasound and they do lung ultrasounds to check for line placement. As now we haven't started, the project is still under process, just to make sure that we have the confidence to say that I can do an ultrasound and I don't need an X-ray in this case. And this is not a dilemma in the unit only, this is an international dilemma that whether we can replace X-rays by ultrasounds because they are safer. So at the beginning of the study, this was the situation. You can see that the MAS is all over. You have 1, 2, 3. And here, to have an MS of 3, that means that the patient is getting high, it's beyond the benchmark. We had quite few, like 30% of the babies, they were getting an MS above 1. And we had about 24% of the DAPs were above 2. So we did the initial phase of minimizing this, and in the first few months, like four months after implementing the X-ray stewardship, we were able to minimize to more than 14% only above 1. Sorry, this is 14% above 3. This is a comparison of the parameters which we are monitoring pre and post implementation of the study, and you can see that we could reduce the DAP to above 2 by 18%, and we also reduced the MAS. This is the results of the study. We had we studied at the beginning of the project around 395 X-rays, and this was like a manual review of all X-rays because at that time we didn't have the dose. And when we worked with the PAC system and they introduced the doses to be reflected in the images, we could retrieve 5 years back. So it was even the old X-rays which were stored in the system, it came with retrospective. Our mean gestational age of the patient who were involved in the study was around 28 weeks. And at the beginning of the study, we had around 91%, around 23% of the babies who had a DAP above 2, KVP around 11% almost. And in this slide, you can see the project impact. So we could change around 73% of MAS, reduce those MAS above 1 by 73%, and KVP by over 60 by 46%, DAP above 2 by 77%, and improper collimation by 34%. We also looked at the quality of the images, and we optimized proper rotation of the babies, and we could minimize around 55% of the rotated films. So the home take messages, we need an neonatal-driven radiation stewardship in each unit. I'm not sure about my colleagues in the other hospitals, whether anybody is monitoring the cumulative radiation dose, but we need to track the cumulative radiation dose because of the long-term risk on this population. Protecting preterm babies from the effect of cumulative radiation is not a choice. All NICUs should adopt radiation stewardship and ALARA phenomena. Thank you.
Thank you, Dr. Salima. I think we'll open a window of discussion after the session of presentations. I would like now to present Dr. Hilal Al-Mandari. Dr. Hilal is a Senior Consultant Neonatologist and Head of Neonatal Intensive Care Unit at the Sultan Qaboos University, the University of Medical City. He graduated from College of Medicine and Health Science at Sultan Qaboos University. He completed his pediatric residency at McGill University, Canada, and he completed his neonatal perinatal medicine at University of Toronto. He also did his fellowship at neonatal transport and pediatric simulation from University of Toronto. His passionate is about neonatal research, currently having 18 publications and 135 citations. His research interests focus on wearing from mechanical ventilation, neonatal transport, and neonatal nutrition. Welcome, Dr. Hilal.
Assalamu alaikum and good morning, everyone. To start, I would like to thank the organizing committee for giving me the opportunity to present this research project, which is titled as the Cross-Sectional National Survey of Neonatal Transport Services in Oman, and I would like to call it as a call for safe neonatal transport. And before I start, I would actually like to acknowledge the hard work of my research resident, my co-researcher in this project, who did a great work completing this research under my supervision. To start, I also like to say that I don't have any conflict of interest related to this talk. Neonatal transport is a necessity, as you have heard from today's talks in the morning, and it is a necessity because oftentimes high-risk neonates are delivered in resource-limited institutions, so they need to be transported for advanced medical and surgical care. Once they receive the advanced medical care, they also need to be transferred back to their home institutions. And within the hospitals itself, newborns need to be transported within the hospital for various procedures and to the operating theater and to the radiology department sometimes. So it is a necessity. However, transport is not without any morbidities. It carries high risk for those newborn babies. Neonates are at high risk for hypothermia and also hyperthermia as well, if you're not controlling their temperature well. With transport, if you're not doing it well, hypothermia is a high risk. Hypoxemia and hypercarpia are also other morbidities. Poor perfusion, hypotension as well, and hypoglycemia. So to be able to do transport safely, there are, I would say, 3 important pillars that you need to work on to have a transport system that is safe. You need to have a trained transport team, specialized transport equipment, and the transport vehicles itself. We'll go slowly through them. So the transport team need to consist of staff who have adequate training and experience in managing sick neonates, and also have the ability to troubleshoot the specialized equipments used for the transport. There are various combinations and configurations of team members being reported in literature. A team may consist of a physician and a nurse and an RT, or a nurse and a nurse, and there haven't been much difference in terms of the outcome of the transport in studies that compare different configurations. When you're transporting a neonate, you're basically moving an NICU. So you need really specialized transport equipment, including a transport incubator attached to a stretcher, which is important to maintain the baby in a thermoregulated environment to prevent hypo and hyperthermia as well. A vital signs monitor is crucial for continuous monitoring of the vital signs. Transport ventilator is very important to deliver invasive and non-invasive respiratory support for the sick neonate, and hence preventing the risk of hypoxemia and hypercapnia. Infusions and syringe pumps are also vital because you need to run continuous flow of IV fluids, dextrose, and infusion medications like inotropes. And that cannot be done without having infusion pumps. Neonatal restraint system to allow the baby to be safely tucked inside the transport incubator and prevent any injuries related to the traffic. Batteries are important to power the equipment. Suction machines are necessary for clearance of secretions from the airway and preventing hypoxias related to airway obstructions. There need to be emergency equipment like positive pressure ventilation device, oxygen supplies, and medical air, and emergency medications. A transport vehicle or an ambulance needs to be well ventilated and air conditioned. It needs to have a locking system for the stretcher that is compatible with that of the locking system in the ambulance is compatible with that of the stretcher of the transport incubator to able to fix the transport incubator inside the ambulance and preventing from movement and preventing injuries to the patient and to the staff. Power supply needs to be compatible with the transport equipment. The ambulance needs to have gas supplies of air and oxygen and medical air, and there need to be also enough room for the team and maybe a parent. A systematic review, which was endorsed by the WHO and published in the Pan American Health Organization, concluded that this systematic review looked at basically the transport in developing country settings. They looked at the final recommendation that there need to be a good establishment of transport system with a focus on the critical and basic issues of physiological stability, with a focus on the need for the proper equipment, vehicles, and training and staff availability. Hence, we conducted this research project, which was with the objective to assess the current state of and the quality of the neonatal transport services in Oman, with the hope and the aim to provide objective data on the necessary changes that would aid in advancing our neonatal transport programs in Oman. The study was a survey-based cross-sectional study, included the healthcare institution across Oman that provide neonatal, pediatric, and maternity service. The survey was developed using multiple international resources that define the optimal standards for neonatal transport. After the initial drafting of the survey questionnaire, the survey underwent a validation phase where it was distributed to 9 consultant neonatologists around the country, and each question was rated either relevant, not relevant, and absolutely not relevant. And accordingly, we calculated the validity index scores, and based on the results of the ICV score, some of the questions were returned as they are, some of them were changed or modified, and some were eliminated. With the final survey was later made into an online survey through the Google Forms. We calculated the number needed to the number of the sample size that we need to distribute to be 83 institutions. The study was actually approved ethically by the Ministry of Health's Center of Studies and Research, and also by the Medical Research Ethical Committee at Sultan Qaboos University. So let's dive to some of the results of the study. We distributed to survey to a total of 96 institutions with got a response from 62 with a total response rate of 64%. Looking at the governance distribution of the institutions, the highest rate or response rate came from Dhofar Governorate with 40%, then followed by South Al-Sharqiyya Governorates with constituting 30.6%. And if we look at the level of care on those institutions, the majority of the institutions responding back in the survey were primary health centers, constituting 66.1% of the responding healthcare institutions. Now, looking at the questions related to the personnel, to the transport personnel and staff, 80.6% of the institution reported having no dedicated leader for the neonatal transport, and most of the transport team configuration commonly reported by the institution was doctor-nurse configuration, and what was reported in 83.9%, followed by single nurse in 53% of the institutions, and the third would be the two nurses in 9.7%. And based on the survey, that most of the institutions said that the team configuration would be variable based on the patient condition and clinical stability. 72.6%, they said they don't have a dedicated neonatal transport team, and 14 institutions, or 22.6%, have designated staff who does the neonatal transport. 14.5% reported having trained staff specifically for neonatal transport. That is only 9 institutions out of the 62. And however, 74 and actually most of the institution, like 74.2, indicated they don't have like minimal requirement to certify the team to go on transport. Looking at the vehicle or the transport ambulance, there is no dedicated transport vehicle for neonatal transport in 63%. So they share basically the ambulances with the rest, with transporting other adult and pediatric patients. 40.3% have no specific speed limit, and a lot of them actually, they were not aware whether there is a speed limit that they need to follow. 62% reported that their transport vehicle were stable. Most of the institutions, 72, said they're adequately ventilated and their air conditions in almost 80%. Now looking at other equipments. So one of the important equipment is the transport incubator. Actually, this is an alarm here, where actually 61%, they do not have access to the transport incubator. Only 16% reported always using the neonatal transport for transporting newborns. 59, almost 60% never actually used a transport incubator. And as a result, most of the time, they are using they are transporting the mother on either a baby cradle or on a staff or mother's lap. Now looking at the transport ventilator, it's not available also in 61%, similar to the transport incubator. And only 27% of the institution reported that they are using transport ventilator consistently when they're transported at an intubated neonate. And as a result, those institutions, they often use the self-inflating bag or ambo bag when they are transporting ventilated or intubated patients. Other equipment, thanks that most institutions, they have transport vital signs in about 93%. They have 50% only have, actually 50% reported have no syringe pumps for giving infusion of medications. And the majority of institutions reported having oxygen cylinders, which is good. Now, safety measures. One of the important safety measures is to check the regular checkups of equipment, which is practiced by around 72% of the responding institutions. And when we ask them the frequency of checking the equipment, most, the ones who are checking, 30% almost, they're checking daily. But there are some institutions who check monthly, and there are some who check weekly, which is not actually, the equipments need to be checked at least every shift and after every use. 64.5%, they reported having no safety restraints. And when we talk about safety restraints, we're talking about something like this. And the idea is to prevent the baby from actually flying if there is a sudden, like flying inside the transport incubator or the ambulance, if there is a sudden break from because of the traffic. The presence of local transport guidelines was available in about almost 60% of the responding institutions, which is not too bad. We asked them about the complications, and specifically we focused about whether they recall having any mortalities related to neonatal transport. And 16% or 10 institutions reported having previous case mortalities related to transport. And when we combined the reasons, most of the reasons were related to either delay in transport, lack of equipment, lack of trained staff during transport, and non-functioning equipment. And as a result of what you have seen so far, most of the institutions were actually not satisfied with the services that they are delivering. About 50% were not satisfied. So in conclusion, neonatal transport services in Oman have critical deficiencies in staffing, equipment, safety measures, and also the availability of guidance. The findings in this study underscore urgent need for building a well-coordinated and well-resourced neonatal transport system supported by standardized national guidelines. Moving forward, our recommendation as a research team is that we need to improve the infrastructure by establishing dedicated and trained neonatal transport teams, and also ensuring availability of appropriate equipment. Now, considering the geography of the country, I know it is one of the hurdles, but probably the best model is to have dedicated transport teams that are located in hospital-based regional transport teams, and these teams would be responsible to be retrieving critically ill neonates from smaller hospitals. As you have seen, most of the responding centers were actually small hospitals that it is obviously quite expensive to have transport equipment in every small health institution. So the ideal situation in this case is to have hospital-based transport teams located in the regional hospitals who will be dispatched to retrieve ill neonates from small hospitals, and also will be responsible for transporting sick neonates from secondary hospital to tertiary care centers. In that way, we will be able to reduce the amount of cost in equipment and direct the funds towards training and establishing dedicated neonatal transport teams. And this is the end. Thank you for listening.
Thank you, Dr. Hilal, for this fruitful presentation. Inshallah, we'll open the window for discussion, maybe sometime later on. I can see some people already having some questions to ask. But we'll have to move on, and then we'll do a collective discussion session. We'll move on to our next session held by إن شاء الله الجلسة الحوارية راح تكون بالعربي إن شاء الله. But I would like to present Dr. Fanna Al-Aramiya, who is going to moderate this next session. Dr. Fanna holds a Bachelor of Medicine Surgery from Faculty of Medicine. She also holds a Family Medicine Residency Program from OMSB. She has Master's degree in Public Health from School of Medicine at the University of Wales. She also holds a Diploma in Child Health Care from Royal College of Physician and Surgery in Glasgow, and another diploma in diabetic care in primary care centers. And she is a PhD candidate from at the University of Wales, Trinity St. David at the United Kingdom. She is the national focal point for integrated child health care at the Ministry of Health, and she holds many awards, such as an award from Arab countries competition in health promotion program at the Sultanate of Oman. She also holds the second place in the excellence competition organized by the Ministry of Information, and she holds the Omani Woman Award, which is at a national level in 2019. COVID Warrior Award, which organized by Vision, and Apex Middle Event at 2020. Welcome, Dr. Fanna Al-Aramiya, and we would also like to welcome the panel as well.
بسم الله الرحمن الرحيم. بس أبي أقول شيء، والله هذا البايو أنا ما أعطيتهم، أنا ما أعرف من وين هم ما جابوه. فأنا من النوع الناس والله ما أحب هذه الأشياء، لكن الله يخلي جدو جوجل والله. وهذا اليوم بإذن الله سبحانه وتعالى موضوع حوارنا إن شاء الله. طبعا بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. طبعاً اليوم أنا سعيدة جداً وفخورة حقيقة وممتنة لله سبحانه وتعالى إنه أعطاني هذه الفرصة بإذن الله إنه أكون حاضرة لهذا اليوم الوطني الطيب. ونحن نحتفل بإذن الله سبحانه وتعالى ب 17 سبتمبر، هذا اليوم اللي أتوقع كل الخدمات الصحية بإذن الله موجهة لي سلامة المرضى بإذن الله، وتجويد الخدمات والوصول للرفاه الصحي. طبعاً تشرف كذلك بإذن الله سبحانه وتعالى إنه اليوم أدير هذه الجلسة الحوارية لهذا الموضوع الصحي الاجتماعي الاقتصادي التعليمي ألا وهو تأثير حقيقة الاستخدام الغير رشيد للأجهزة الإلكترونية. طبعاً أتشرف بإذن الله سبحانه وتعالى بوجود بوتقة من الخبراء الزملاء من سلطنة عمان، وكذلك يشرفنا الزميل من المملكة العربية السعودية، لهم كل التقدير بإذن الله. يعني معرف المثل أهلاً وصلتونا أهلاً وستتركوننا بإذن الله سبحانه وتعالى أهلاً. لهم كل المحبة والاحترام والتقدير. طبعاً ببدأ بإذن الله سبحانه وتعالى إنه أرجو إنهم يقبلوا دعوتي بإذن الله لتكرم لمنصة جلسة الحوار. طبعا ما أحلاها من طبيبة أطفال. أنا كثير أفرح حتى حقيقة لما أشوفها، يعني سبحان الله، من الوجوه الباسمة اللي الحمد لله، يعني هذه أنا أعتبرها نعمة من الله سبحانه وتعالى. أبدأ بصاحبة السمو السيدة الدكتورة خولة آل سعيد، وطبعا أختنا بكل ما تحمله الكلمة من معنى. هي استشاري أول في أمراض الجهاز الهضمي للأطفال بدائرة الأطفال في المستشفى السلطاني، المديرية العامة للمستشفى السلطاني. طبعا ما شاء الله البايو طويل، بكالوريوس علوم، دكتوراه في الطب، زميلة أكاديمية للأكاديمية الأمريكية لطب الأطفال، زمالة في الكلية الملكية للأطباء والجراحين ما شاء الله. وهي ما شاء الله عليها يعني ما تحتاج تعريف، قائدة من القيادات البارزة حقيقة في مجال طب الطفولة هنا معنا في سلطنة عمان. شاركت يعني في كل شيء، يعني في مراحل التفكير، مراحل التخطيط، مراحل التدريب، مراحل المتابعة لكل الطفرة هذه اللي احنا نعيشها في بإذن الله سبحانه وتعالى تخصص طب الأطفال. أهلا ومرحبا حبيبتي، نورتي.
شكرا على هذه المقدمة الحلوة، حسيت نفسي يعني من الأجيال القديمة جدا. فشكرا.
على ذكر هذه الكلمة، الأسبوع الماضي كنت أحضر الأسبوع التعريفي لطلبة جامعة سلطان قابوس، وكان في بنات فيسألوني دكتورة فنة أنتي متى داخلة الجامعة؟ قلت لهم 1989. قالوا حسيت نفسي قديمة يعني خلاص موديل مالي منتهي. عاد استحيت واحدة فيهم بتقولي، قلت لها أنتم متى داخلين؟ قالت تو هذه السنة. استحيت تقول لي أنت مولودة أي سنة، لأن أنا قلت لها أنت مولودة أي سنة؟ قالت لي 2007. خفت تقول لي أنت مولودة أي سنة، مفروض بعدين تقول لي دكتورة أنت ديناصور، مفروض تكونوا منقرضين. فهذا هو طب الأطفال حقيقة، يعني يخلي الإنسان الهيومانيتي ماله غير حقيقة. يعني كثير طب الأطفال سبحان الله ينعكس عليهم. طبعا الضيف وضيف الله، أهلا ومرحبا بأخونا الدكتور طارق العايد، نطقت القبيلة. تفضل دكتورنا الكريم، استشاري أطفال وعناية مركزة أطفال، رئيس العناية المركز للأطفال، مستشفى الملك فيصل التخصصي ومركز الأبحاث بالرياض، الرئيس التنفيذي للمجموعة السعودية للعناية الحرجة، نائب رئيس الجمعية الخليجية للعناية المركزة للأطفال، أستاذ مشارك بجامعة الملك فيصل، وماجستير إدارة طبية في جامعة الملك سعود. أهلا ومرحبا دكتورنا الكريم. تتفضل هناك دكتور، آخر كرسي. طبعا يعني ما شاء الله، ما أعرف هل هو هذا evidence based يا أخي. حتى مسؤولات الأطفال دائما مبتسمات، واستشاريات الأطفال دائما مبتسمات. ما أعرف ويش السر، لازم نعمل دراسة على هذا الجانب. طبعا أتشرف وإذا بتقبل دعوتي الدكتورة العزيزة الدكتورة ناهد جابر، يعني والله من الخبرات الكبيرة حقيقة في مجال طب الأطفال بتخصصه الفرعي هنا معنا في السلطنة. دكتورة ناهد استشاري أول في طب الأطفال وطب مراهقين، رئيسة وحدة طب المراهقين بسلطنة عمان، طبعا خريجة جامعة تورونتو كندا، وما شاء الله عندها يعني بايو قوي جدا جدا جدا. مدربة سريرية في جامعة تورونتو حاليا، عضو هيئة تدريس في المجلس العماني لاختصاصات طبية، مؤسسة خدمات طب المراهقين ما شاء الله عليك في سلطنة عمان، وقائدة برنامج الانتقال من رعاية الأطفال إلى رعاية البالغين. لها انترست كمان الله يحفظها إنه حتى لما بدينا أنا وياها الكلام يعني كانت كل تفكيرها how to promote الرفاه، كيف نرفع جودة الحياة بالنسبة للمراهقين هنا معانا بسلطنة عمان، ونربط الحياة وتأثير التحديات الظروف المحيطة بالمراهق والأمراض المزمنة، كيف إنه بإذن الله سبحانه وتعالى ويدخل فيها أمور أخرى. أهلا وسهلا دكتورتنا ونورتي.
شكرا جزيلا، خجلتيني.
طبعا ما شاء الله عليك يا ملك، يعني ضيفة من ومشاركة حقيقة من وزارة التنمية، الأخت ملكة باعمر، ما شاء الله عليها. هي جايتنكم على فكرة متحمسة وعدها قصص جميلة ناخذ منها عبرة إحنا للمجتمع، خاصة للقيادات الصحية، حول دور التأثير السلبي حقيقة لاستخدام الأجهزة الذكية الغير رشيد، وكيف أن وزارة التنمية الموقرة ما شاء الله عملت معايير خوارزميات استرشادية لهذا الجانب. إذن نبدأ بإذن الله، نلتزم جميعا بالوقت المحدد، وأذكر وأقول بإذن الله سبحانه وتعالى إن احنا على الهواء، بمعنى إنه كل المجتمع معنا يعني يتابع بإذن الله سبحانه وتعالى هذا الحوار الطيب. طبعا الندوة بإذن الله الفوكس مالنا اليوم استخدام التكنولوجيا على صحة الأطفال وتطور الأطفال وتطور التكنولوجيا. طبعا مقدمة ما عندي شيء أقدمه، يعني بإذن الله سبحانه وتعالى 90% كلكم آباء أمهات أو خلان أو خالات، عمات أو أعمام الأطفال. شفتوا بالضبط العقدين السابقين، أول ما دخلت الألفية ودخلت معانا هذا النهضة القوية في الحياة التكنولوجية، ودخلت الأجهزة الذكية وأخذت أشكال كثيرة حقيقة، وصارت متاحة للكل وبأسعار يعني تتنافس فيها ما أقدر أقول الشركات، لكن الجهة اللي توردها بحيث أنها تكون سهلة ممكن الواحد يوصل لها. هذه واجد أثرت علينا حقيقة، صدقوني، ما أقول فقط في العواصم، وإنما كمان عندنا يعني في الداخل، وأنا واثقة يعني المملكة العربية السعودية يمكن كمان الدكتور بيتفق معنا إنه بالفعل هذا الأجهزة الذكية صارت كون إنه العالم قرية واحدة ما ترتبط بمستوى عن مستوى، الكل للأسف صار يعاني من هذا الموضوع. نبدأ بإذن الله بصاحبة السمو السيدة الدكتورة خولة. دكتورتنا لك المجال بإذن الله سبحانه وتعالى، تفضلي.
أهلا وسهلا بكم. طبعا التأثيرات اللي تصير على الأطفال مهمة جدا إنه المجتمع يوعى بها، وإحنا بعد مشاركين في هذا كأطباء أطفال إنه نوعي الناس بعصر الرقمي هذا، لأنه الحين هذا شر لا بد منه، فما نقدر إنه نقول لا امنعوا الأطفال وهذا هو، لا، هو الموضوع محتاج أشياء كثيرة على عدة مستويات. فأولا لازم نرجع للتوصيات من المؤسسات العالمية الانترناشنال جايدلاينز بشكل عام. الأطفال اللي أقل من 2 المفروض ما يكون حواليهم أي جهاز. طبعا احنا اللي نشوفه الحين غير، معظم الأطفال تلاقيهم مع أهاليهم بس عشان يسكتوهم تلاقي الجهاز بإيدهم. فالتوصيات تقول إنه الأطفال اللي أقل من 2 مفروض ما يكون عندهم أي وقت على الشاشات الرقمية أو الأجهزة هذه، إلا في حالة واحدة للتعامل، يعني مثلا عندهم أهل موجودين في أماكن أخرى ويريدوا يكلموهم عن طريق التواصل المرئي بحضور الأهل، فهذا متاح لهذين الأطفال الأقل من 2. الأطفال اللي من 2 إلى من 2 إلى 5 سنوات هذول الأطفال مفروض إنه يكون تحت إشراف الأهل وما يتعدى أكثر من ساعة، وفي بعض المنظمات حتى توصي أقل من ساعة، ولازم هذه الساعة تكون ذات محتوى له معنى، بمعنى إنه معنى تعليمي أو ثقافي، ويكون بحضور الأهل، ما إنه بس نعطيهم نقول لهم يلا شوفوا هذه البرامج وتثقفوا، لا، لازم يكون معاهم الأهل على أساس إنه يكونوا معاهم ويعلموهم أول بأول إشراف الأهل. عد أكثر من 6 سنوات المنظمات اختلفت على حسب توصياتها، لأنه الحين اللي فوق 6 سنوات يستخدموا هذه الأجهزة الذكية حتى في المدارس، فعشان كذا ما كان في يعني أيوة معين، بس الكل في الموضوع إنه الأهل لازم يكونوا موجودين ومشرفين على الأوقات اللي هم على هذه الأشياء الرقمية. طبعا جت هالتوصيات وهذه الأشياء كلها لأنه هذه مهمة فعلا من ناحية من كثر ما شفنا الأعراض الجانبية من فرط استخدام هذه التقنيات. طبعا آثار يعني يمكن واحد لأكثر شيء عارفينه اللي هي السمنة وتأثيرها، لأنه الطفل سواء وإحنا لما نتكلم أشياء رقمية حتى ندخل في الألعاب الإلكترونية اللي فمش بس الإنترنت بس حتى في الألعاب الإلكترونية وكثير منها أصلا على الإنترنت، فهذه تسبب السمنة لأن الطفل قليل الحركة ويقعد بالساعات على هذه الأجهزة، وأحيانا يأكل لا واعي من غير ما يوعى، قاعد يأكل وهو على هذه الأجهزة. فالسمنة واحدة من المشاكل اللي صرنا نشوفها بكثرة، يمكن زمان ما كنا نشوفها كثر ما نشوفها الحين. الأشياء الثانية يمكن بعد بترك مجال لبقية الضيوف يتكلموا فيها، بس من المجال الثانية المهمة المشاكل اللي تصير في المدارس من تأخر دراسي وكذا، جزء منه لأنه تأثير الأجهزة الرقمية بشكل عام على تركيز الطفل، وكذلك على نوعية النوم اللي ممكن يناموها. إذا الطفل لحد آخر لحظة عنده الجهاز قبل ما ينام عليه ويقوم عليه، لأنه ما في تحديد لهذه الساعات ما بين عوائلنا، وإحنا هذا اللي نريد يعني مع كل زيارة في مركز صحي في مستشفى إنه الكل لازم يوعي الناس بخطورة هذه الأشياء. إحنا نعتبره شيء بسيط بس هذا فعلا ليها كثير مضار صحية، فمنها مثل ما قلت إنه الطفل ممكن يتأخر دراسيا، أو ممكن حتى تتأثر شبكة العين من كثر ما يستخدموا هذه الأجهزة. فهذه واحدة من الأشياء الصحية اللي ممكن أتكلم عنها. وطبعا هذه مشاكل في الأطفال اللي ممكن نقول 10 سنوات أقل، يمكن فترة المراهقة عندهم مشاكل أخرى. يعني هذا ناتشل باختصار.
بارك الله فيكي، ويعني كلام جميل ومن ما شاء الله يعني تاريخ خبرة، يعني ما أقدر أقول عظيم العظمة بالله سبحانه وتعالى، لكن بإذن الله سبحانه وتعالى مثمر. دكتورة كمان في نقطة إنه حتى كونك إنك أنت استشاري أول في أمراض الجهاز الهضمي أطفال، فحتى يأثر عليكم لما تجوا يعني تعملوا وصفات علاجية لمراض مرتبطة بالطفولة في الجهاز الهضمي، وتجي تطلع الأم بالطفل وتعطي الجهاز الذكي وتقول له خذ. ما شاء الله الحين يعني كل حد شاطر إنه يدخل في النص ويلخبط خطط علاجية قد تأخذ سنوات وأنتم تحتاجونها على أساس بإذن الله سبحانه وتعالى تسيطروا على المرض اللي عنده هذاك الطفل. فهي ما هي بس سمنة وبس، حتى هو يعني يدخلوا كذا عرض في مواضيع قد لا يكون الوقت مناسب حالها.
هو فعلا يعني يجي كثير من الأهالي قرأ على جوجل، والحين شات جي بي تي في الموضوع يشاركنا خبراتنا اللي شفناها. فدائما أنا أوعي الأهالي أقول لهم صح هذه المعلومة مذكورة بس ما يعني ما سبيسيفيك، يعني ما محددة لطفلك. يعني أيوة أنا درست لمدة 7 سنوات على أساس وأشوف الأنماط المختلفة وبعدين بحكم لو طفلك في هذا النمط ولا لا. بس لو بتسألي جوجل ولا شات جي بي تي بعطيك فكرة عامة من غير الخبرة الإنسانية. وأعتقد إحنا كأطباء بشكل عام الجانب الإنساني هو اللي يتدخل في العلاج أكثر من بس مجرد إنه هذا هو المرض وهذا هو العلاج. أيوة، يعني مثلا بيجيني الأهل، أنا في الجهاز الهضمي أكثر شيء اللي الأهل يسووا عليه أبحاث اللي هو لما نوصي إنهم يحطوا أنبوب التغذية، فبتلاقيهم خلاص جايين بنشرة كاملة أنواع الأنابيب وكذا. فأنا أقول لهم في النهاية خليك هذه معلومات عامة، أنتوا إيش يناسبكم في بيئتكم، يعني هذا اللي احنا مع بعض بنقرره، مش تشات جي بي تي ولا الجوجل بيخبرك، انتوا خبرونه. هذا هو النقاش. فهذه الاشياء انا احسها يعني من جهة ما يتحدى الدكتور بشكل حلو، يعني يخلينا نوسع احنا بعد مداركنا ونوسع الجانب الانساني من مهنتنا. فانا اشجع مثل هذه الاشياء، بس طبعا بحدود.
بارك الله فيكي. وآخر سؤال لدكتورة خولة، هل الطفولة بمراحلها، قبل أن ندخل بإذن الله للدكتورة العزيزة الدكتورة ناهد، بالنسبة للطفولة دكتورة، هل هي فقط مرحلة ما قبل الدراسة اللي هو الأقل من 5 سنوات، أو تكثر الأهل يكونوا كثير مع الأجهزة الذكية ويدخلوا للأسف بمعتقداتهم بسلوكياتهم الغير صحيحة وتؤثر على الطفل وتأثر عليكم أنتم كأطباء متخصصين في هذه الفئة العمرية، أم أن حتى فترة الدراسة يعني حتى اللي أعمارهم قبل أن يدخل فترة المراهقة؟
أكيد فترة الدراسة من الفترات المهمة، فتقنين هذه الأشياء كثير مهمة. مثل ما ذكرنا في البداية ممكن حتى يتدخل في الدراسة على أساس أنه الطفل يقضي كثير أوقات على هذه الأشياء. بس شيء واحد مهم للأطفال اللي ما دون 2 لأنه 2 سنين، لأنه صرنا نشوفها كذا بكثرة حتى في الأسواق وكذا، أنه هذا ممكن يتدخل في نموهم التطوري، ولأنه الطفل يتعلم بالمشاركة مع الآخرين، باللعب مع الآخرين، بالأشياء الحسية، بينما الجهاز يعطيك 2 dimension، يعني ما في محادثة وكلام. حتى صرنا نشوف إن بعض الأطفال يكون يعني ما أقول توحد بس سمات التوحد من ناحية إنهم هم اللغة عندهم ما متطورة، ولا أحيانا متطورة بكثرة، لأنهم كل اللي يسمعوه من الجهاز تلاقي اللهجة عندهم الأكسنت كثير إنجليزية وفاهمين اللي هم يقولوا، بس ما في هذا التحادث اللي قاعد يصير. فكثير يأثر على الأطفال اللي ما قبل الدراسة. أنا أحس طبعا مشاكل اللي ما بعد الدراسة مشاكل أخرى تكاد تكون أكثر شيء يمكن اجتماعية وجسدية. ويمكن أرجع لك بسؤال لو
يعني نكمل مع الدكتورة ناهد الله يحفظك. وطبعا سبحان الله مرحلة المراهقة من أصعب المراحل اللي مر فيها الإنسان. أنا ما أعرف هل هذه الجملة صحيحة ولا لا. شوفها ثumb raised، هل هو التغيرات شوفوا صار في ديبيت، واحدة قالت لا، واحدة رفعت إيدها، ما نعرف المجتمع إيش، لكن أنا مع إنه صح يمكن التغيرات الفسيولوجية، يمكن كمان المرحلة يعني الاحتياج التعليمي، توقعات الأهل كمان كثير كثير تدخل في هذه المرحلة. فهو طلع من مرحلة الطفولة، طلع من مرحلة إنه نوعا ما في سيطرة من الأهل، تو دخل في مرحلة أنا المراهق اللي يعني يبي يجرب، يبي يستطلع. هنا جات العادات والسلوكيات مش صحيحة. دكتورة نبدأ، دكتورتنا الغالية دكتورة ناهد، نبدأ من ما انتهت به الدكتورة خولة.
شكرا. هلا طبعا اللي بلشت فيه دكتورة خولة واللي انتهت فيه هو الفاونديشن، هو الأساس. يعني أنا ما بقدر أوصل على مرحلة مراهقة سليمة إذا ما أسست من البداية على كيف بدي استلمهم بوقت مرحلة المراهقة. يعني أنا بس بسألكم كلكم وعذرا منك دكتورة فنا، مين عنده تينيجرز بالبيت؟ يا خي يا أخت يا بنت يا قد في تحديات عندكم بس على استخدامهم للأجهزة الإلكترونية فقط؟ واغلب النزاعات اللي انا بشوفها بالعياده يعني ريجاردلس السبب اللي بيكون تحول فيه المراهق لعيادتنا شو ما كان السبب، لما بنعمل عمليه المسح او الاسئله الروتينيه اللي من ضمنها اسئله عن استخدامهم للاجهزه الالكترونيه وقد ايه بيقضوا وقت على الاجهزه الالكترونيه وهل في نظام بالبيت، اغلب النزاعات اللي بتصير بين التينيجرز واهلهم لها علاقه باستخدامهم للاجهزه الالكترونيه. طبعا هذا مردوده لاكثر من سبب، بنبدا فيهم وحده وحده. يعني مثل ما قلنا مرحله المراهقه هي مرحله تغيرات كثير كبيره، يعني كانه يعني انا بدي اقول مثل نوع من الثوره اللي عم تصير بكيانه لهالشخص، تغيرات فيزيولوجيه، تغيرات نفسيه، تغيرات بعلاقته الاجتماعيه، عم بيحاول يخلق ايدنتيتي له بهذا المجتمع، عم بيحاول يكون اندبندنت. الاهل ما رح يعني مش ماشيين معه على نفس الخط ونفس الموجه انه اوكي هيدي مرحله وحنرافقوا فيها. بضلوا المراهق بعيون اهله هو طفل، فهون بيصير موضوع النزاعات اللي طبعا اسبابها كثيره، وهذا الشيء طبعا بنشوفه بالعياده. السؤال انه شو هي المضاعفات او المشاكل اللي بنلاحظها نتيجه الاستخدام المفرط، وانا هون رح اقول الاستخدام المفرط. يعني باي ديفينيشن الاستخدام المفرط هو حسب الدراسات اي استخدام اكثر من 3 ساعات غير الادوكيشنال يوز. يعني إذا حدا عم يستخدم الأجهزة الإلكترونية for 3 hours لeducational purpose مختلف عن الساعات اللي بيستخدمها recreational يعني للفن والانترتينمنت والفيديو جيم. فبدنا نلخصهم يعني مضاعفات على الصحة in general، الصحة الجسدية والصحة النفسية. إذا نحكي على الصحة الجسدية وهذا بيشمل طبعا اللي أقل من 10 والمراهقين بنفس الوقت، يعني اضطرابات مثلا بالنوم خصوصا لما بيتأثر هرمون الميلاتونين وبأثر على السايكل تبع النوم. لما النوم بيتأثر مش بس بنكتفي بموضوع النوم والكواليتي اوف ذا سليب، ممكن يجيب معه توتر والقلق والتراجع بالمستوى الأكاديمي لأنه ما بننام منيح بالليل، يعني بنروح الصبح على السكول عنا لاك اوف سليب، يعني ما رح نقدر نركز، يعني تيتشرز حيبلشوا ينتقدونا، يعني تراجع بالمستوى الدراسي وسايكل بنفوت فيها. غير موضوع النوم تأثير على موضوع النظر والجفاف العين والاضطرابات اللي قالت عنها دكتورة خولة بموضوع النظر، هيدي شاملة بمرحلة الطفولة ومرحلة المراهقة، بالإضافة لآلام بالظهر وآلام بالرقبة، وصار في يعني physical deformities يعني سواء بالرقبة أو بالإيد عند الجنريشن اللي طالعين جديد جيل التكنولوجيا. نرجع لمرحلة المراهقة، المشاكل أو المضاعفات اللي أكثر شيء حنحكي فيها ونفسية، وهي نفسية وسلوكية بنشوفها بشغلنا مع المراهقين بالعيادة. توتر والقلق. هلا السؤال انه الاهل اوكي الاجهزه الالكترونيه بتسبب توتر وقلق هي لحالها ولا بيكون اصلا البيس لاين عنده توتر وقلق؟ التوتر والقلق ممكن يكون عامل وراثي وممكن يكون يزيد مع استخدامنا المفرط للاجهزه الالكترونيه، فالجواب على الاثنين ممكن توتر وقلق يعني منفصل، أو توتر وقلق وحتى اكتئاب يزيد باستخدامنا المفرط، وهذا الشيء مبني على أبحاث يعني مدعم ببيست ايفيدنس إنه بيزيد. وهون رح ركز أكثر على يعني بعض البلاتفورمز خصوصاً انستغرام وسناب شات، وميل التركيز هون رح يكون على الفيميل أدوليسنت، اللي طبعا الدراسات لقت انه الريليشن بين الانستغرام يوز والبادي ايمج عند الفيميلز، خصوصا انه مجتمعاتنا يعني شوي بنكون اورينتد على البنات انه الشكل والحجم والشيب والسايز، وحتى قبل التكنولوجيا وقبل الريفوليوشن تبع التكنولوجيا بالاسر، يعني كلنا بنتذكر، يعني انا شخصيا خليني احكي تجربه شخصيه بطفولتي، اكيد كانوا الخالات والعمات يقارنوا لما نجتمع كلنا، هي اضعف، هيدي انصح، هيدا اطول، هيدا اقصر، صح؟ فهيدي بتخلق نوع من البادي ديساتسفاكشن وبادي ايمج ايشوز. ما عندي اي بادي ايمج ايشوز، بس some other people ممكن يصير عندهم بادي ديساتسفاكشن ويفوتوا بسلوكيات خاطئه تينزلوا وزنهم بطريقه غلط. فالبادي ديساتسفاكشن بالايرا اوف تكنولوجي اللي صار، الفاشينيستاز والانفلونسرز والبلوجرز مع احترامنا لهم أكيد ممكن يكونوا عم بيقدموا محتوى كتير لائق ومحترم، بس أوقات كتير لازم ناخد بعين الاعتبار التينيجرز كيف رح يفهموا، كيف الانتربريتيشن اوف تينيجرز لما بيشوفوا البلوجرز. وهون مين اللي بيحكي عن موضوع الجسم والبادي شيب، يعني صارت الجمال مرتبط بالنحافة which is wrong. وأغلب البنات اللي بيجوا لعنا على العيادة لو بنسألهم سؤال، نحن عادة بنسأل قولي لي شغلتين بتحبي تغيريهم بحياتك in general، ما بنكون عم نحكي عن بادي أو شيب أو سايز، فورا بيروحوا على البادي، فبتقلك يا نوز جوب، يا بتقلك ماي تيث، أو بتقلك نزل وزني، فكله influenced by السوشيال ميديا. فهذه وحدة من التأثيرات السلبية، بالإضافة للعزلة الاجتماعية، فقد المهارات، التواصل الاجتماعي، يعني صاروا ما بيحبوا يروحوا على الزيارات العائلية، بفضلوا دائما يكونوا مندمجين منفردين ومنعزلين على الأجهزة الإلكترونية. ويعني أكيد تطول يعني السلسلة من المضاعفات والمشاكل اللي ممكن يصير عند المراهقين. طبعا الشباب عندهم غير موضوع الإدمان على الفيديو جيمز والارتباط بالسايبر ستوكينج والسايبر سيفتي والسايبر بولينج والتنمر الإلكتروني، فكمان يعني سلسلة طويلة من المشاكل اللي ممكن تحصل.
يعني أقول لكم على شيء، ترى سبحان الله الزمان يركض، صح النون؟ اللي دكتور طارق مثلا تخصصه عناية حرجة أطفال، بس هذاك اللي في اللي في العناية الحرجة جاي من دخلت مرحلة الطفولة والمراهقة، وممكن تكون أدمنت على الأجهزة الذكية، وفي النهاية انتهت إنها حملت وجابت طفل، يعني انتهى عند هذا. فهو شوفوا هي عبارة عن دائرة، لا تستهينوا بمرحلة، لأن احنا كنا نكمل بعض في هذه الظاهرة اللي بالفعل صدقوني يعني ما هي بصحيحة، ما هي بصحية. أجهزة ذكية جاية الهدف، هدف للمجتمع، احنا لينا كنا للعالم يحتاجه على أساس يتواصل، للطالب، بس ما معناته إنه هو أبوه وأمه وصديقه وصديقته ومجتمع والشخص اللي بيحبه وأحلامه وماضيه لا، لازم كنترول. هنا الكنترول بنسمع تجارب، كون إن الدكتور طارق نائب رئيس جمعية مثل الجمعية الخليجية في المملكة العربية السعودية، كمان هذه الجمعيات جمعيات أهلية، فهي عندها أكثر، يعني عندها تجارب خليج. مثلا الدكتور طارق إذا بيستعرض لنا مثلا إيش الظواهر اللي طلعت معانا بالخليج، بس قبل بنسمع الأخت ملكة. وملكة لو تتكرمي عطينا إيش معنا هنا بالسلطنة، إيش الظواهر اللي ظهرت على المجتمع العماني اللي رصدتها وزارة التنمية على حسب يعني وظيفة، يعني الجوب ديسكريبشن مال الوزارة في المجتمع، وربطوها باستخدام غير رشيد للأجهزة الذكية. تفضلي، تجارب حية.
يسعدني أن أكون جزء من هذا الحوار المثير. طبعا بما أني أخصائية وأتعامل مع الحالات ومع الأطفال، إحدى الأمثلة اللي طرت على بالي من مخاطر استخدام وسائل التواصل الاجتماعي البلاغ اللي تعاملت معه. للأسف طفل تقريبا يبلغ من العمر 9-8 سنوات. أول ما قابلت هذا الطفل للأسف كأني أقابل إحدى الشخصيات الكرتونية، من كثر ما أن الطفل أصبح مدمن هذه الوسائل التواصل الاجتماعي. حاولت أني أرجع لتحليل المشكلة وإيش الفيدباك، كيف وصل الطفل لهذه المرحلة. قابلت الأم على حدة. الأم صرحت لي أنها للأسف مخصصة غرفة في المنزل، هذه الغرفة مزودة بجميع الألعاب الإلكترونية والأجهزة الإلكترونية، كونها تعتقد أنه هذا الطفل إذا خرج في المحيط الخارجي أو احتك مع أقرانه هنا الآثار السلبية التي تترتب على الطفل. هي ما مدركة أنه هذه الوسائل هي أساس المشكلة اللي أصبح هذا الطفل وصل لهذه المرحلة. طبعا الأم عملنا له جلسات إرشاد وتوجيه حول هذا الموضوع، وكذلك الطفل أحلناه إلى دائرة إلى التشخيص لكي نتأكد إذا هذا الطفل في أي اضطراب أو ما شابه إلى ذلك.
ويعني أنا مع ملكة، هو ما هو بطفل، قد يكونوا أطفال، بس هي عطت مثال واحد. عتشوفوا الخدمات الصحية اللي تقدمها وزارة الصحة، وزارة التربية والتعليم، الوزارات المختلفة من أجل التعليم والصحة وانتهى الطفل بأنه كرتون. متخيلين؟ يعني إيش من نفسية عنده هذا الطفل، إيش من إدراك، إيش من ذهن، إيش هذا بيكون عنده يعني في المدرسة. والسبب إنه فقط سوء فهم عند الأم، هي على بالها تحمي من المجتمع الخارجي، فللأسف يعني أعطت فرصة لعدو خارجي عالمي إنه للأسف وألا سامحها الله. تفضلي أعطينا أمثلة، لأنه بعدين ملكة نبدأ مع الدكتور طارق وتتكلم لنا أخوي بالنسبة للجمعيات. نطلع شوي من وزارات الصحة، الجمعيات الخليجية إيش توجهها؟ تفضلي.
هذا مثال واحد طرأ على بالي غير الأمثلة الثانية. يعني مثال آخر، طفل تقريبا ما يقارب العمر 15 سنة. هذا الطفل وصل للأسف مرحلة الإلحاد بسبب استخدام المفرط لوسائل التواصل الاجتماعي. أصبحت لديه عزلة اجتماعية، الطفل صار ما يخرج مع أبوه، يعني ما يشارك أسرته. وطبعا نفس الشيء عملنا له جلسات إرشاد وتم إحالته إلى تشخيص، بحيث أنه نقلل من قيمة استخدام وسائل التواصل الاجتماعي لدى هذا الطفل.
وقف كلامي حتى، والله وقف. صح، وأنا واثقة والله، يمكن ملكة يعني ما تقدر تصرح أكثر. نعم، لكن أنا واثقة أنه كل واحدة فيكم، لأنه أنتم قادة صحيين، شفتوا أكثر وأكثر وأكثر وأكثر. دكتور طارق، يعني ما شاء الله أنا كثير استمتعت بالمحاضرة القيمة اللي أنت قدمتها، جزاك الله كل الخير. دكتور طارق، هني نبي نسمع دكتور طارق اللي هو نائب رئيس الجمعية الخليجية. يعني أخوي هذا الجزء جزء حساس. أتوقع إحنا يعني الدول الخليج متشابهة في كثير من الأشياء، يعني إحنا يعني نفس العادات، نفس التقاليد، نفس توجه الأسر. فبالضبط كجمعيات يعني خليجية أو حتى سعودية، لأن إحنا بإذن الله مثلا دكتورة خولة بتخبرنا بالضبط رابطة الطفولة معاهم، هي تترأسها، إيش كيف هم يحاولوا إنه يوعوا الزميلة في التنمية، بتخبرنا إيش من إرشادات. هذا تفضل دكتور، نبي نسمعكم.
بسم الله الرحمن الرحيم. أول شيء ثانك يو، يعني شكر لكم، شكر لك دكتور فنة والأورجنايزنج كوميتي على اختيار مثل الموضوع هذا. فعلا موضوع يعني مهم، والموضوع هذا كل يعاني فيه. يعني إحدى الدراسات عندنا في المملكة في المنطقة الشرقية 70% من الأطفال اللي عمر 7 إلى 10 سنوات يقضون 6 إلى 7 ساعات يوميا على الأجهزة. هذا طبعا يعني شيء رقم خرافي، وهذا مرض يهدد المجتمع جميعا يعني. والنتائج لن تكون الآن، لكن ستكون النتائج في المستقبل. يعني زي ما تفضلوا الزميلات عن المشاكل الصحية والاجتماعية، وهذه قد ما تكون الآن واضحة، لكن إنها ستضح أكثر في المستقبل. فيه يعني الآن أحد الأعراض، وهذا الأطباء العظام يسمونه تكستينج سيندروم، اللي هو يسبب مشاكل في الفقرات بسبب يعني الطفل دائم يعني منحني. تشوف يعني حالات صراحة، يعني أطفال ترحمهم صراحة، يعني طول الوقت يعني تلقاهم مثل المولات وشيء، راكب العربية والجوال، حتى الجوال حطوه هنا. يعني حتى لما يجوننا في المستشفى لما يبدأ يعني تعالجوا كذا، تلقى جوال وحطه قدام عيونه. ففي مشاكل صحية كثيرة. فهذه يمكن ما نشوفها الآن، هذا ب2 سنتين أو 3 سنين اللي قاعد يستخدم، راح نشوف المشاكل هذه بعد سنوات. الأمر الآن اللي يحتاجه، سواء على مستوى محلي أو على مستوى دول الخليج، يحتاج عمل جماعي، يحتاج توعية، يحتاج ورش عمل، يحتاج لازم الجهود تكون بين المدرسة، البيت، والمجتمع. أنا ما أشوف حقيقة المدارس لها أي دور صراحة في التثقيف عن الأجهزة واستخدامات الأجهزة. ما أشوف أنها للأسف، أتوقع أننا ما زلنا يعني في بدايات الأمر من ناحية توعوية من المدارس. الأهل صاروا للأسف يستخدمون الأجهزة هذه لأبنائهم عبارة عن يعني فكني من شره، خلوهم شيء بس يستخدم الجوال ولا الآيباد ولا هذا بس عشان ما يزعجني ولا قاعد أسوي شغلي أنا ولا شيء. فيحتاج صراحة عمل جماعي. دور الجمعيات أنه يكون له دور فعال في التوعية، وأتوقع هذه واحدة من أساسيات التوعية، يعني أننا كلنا في المجال هذا نتكلم عن هذا، لكن يجب علينا أن نصل إلى المجتمع، يجب علينا أن نصل إلى المدرسة. لازم يكون في جهود على مستوى أفراد، مستوى جمعيات، لأنه ما في طريقة تمنع هذا الحدوث. يعني أذكر زمان أول ما جت الدشوش، الدش في البيت، يعني كان في المملكة كان شيء صراحة يعني أيوة، وكان عيب يعني إن الواحد يحط، وكان الناس خايفة من المشاكل اللي راحتها. وكان طلب من هيئات ومن رئاسات، يعني الأمير سلطان وزير الدفاع سابقا، قيل له يعني شنو الحل وشنو نسوي؟ قال أنا ما أقدر أجيب على كل بيت عسكري وأقول له لا تحطوا يعني دشوش في البيت. فهي ما تقدر تمنع الشيء الآن هذا داخل بقوة، ولا تقدر تمنعه، لكن اللي تحتاج التوعية، تحتاج يعني العمل الجماعي والجمعيات أنها تعمل كلها. كيف أننا نرشد الناس، كيف أننا نوعي الأطفال، كيف أننا نوعي المجتمع والمدرسة على المشروع هذا. شكرا.
دكتور طارق، جزاك الله كل الخير. برجع الملكة، كون أنك أنت بإذن الله سبحانه وتعالى تمثلي وزارة التنمية الاجتماعية الموقرة، وطبعا أنتوا تستقبلوا الحالات، يعني أنتوا للأسف المنتج اللي للأسف دخل في الاستخدام الرشيد للأجهزة الذكية فتستقبلوه، سواء كان مراهق ملحد أو لا قدر الله عنده يعني بكل الأشكال. نبيك أول شيء إنه كون إنه بإذن الله ثيم لهذا العام اللي هو المأمونية، الأمان ما أحلاه، عرفتي؟ فخبرينا بالضبط وزارة التنمية طبعا أكيد عاملة مثل ما ذكر الدكتور طارق، احنا معانا بالسلطنة في جهود متكاملة أكيد مع وزارة التربية والتعليم، وزارة الصحة الموقرة. إيش من جهود معاكم أساس اللي موجودين ينقلوها، كيف إنه المراهق يوصل لكم، وإذا مش المراهق أو الطفل أهله كيف يوصلوا لكم؟
طبعا جهود وزارة التنمية الاجتماعية جهود فعالة. أصدرت وزارة التنمية الاجتماعية دليل إرشادي حول مخاطر وسائل التواصل الاجتماعي. هذا الدليل يتمتع بجميع الضوابط والإرشادات حول استخدام وسائل التواصل الاجتماعي. طبعا هذا الدليل موجه للآباء والأمهات، وما هي الآثار الإيجابية والسلبية لاستخدام وسائل التواصل الاجتماعي، وأيضا الآثار قد تكون اجتماعية وصحية ونفسية مثل ما ذكرتها سابقا.
بارك الله فيكي. وأكيد طبعا هذا تم نشره وتم بإذن الله سبحانه وتعالى عن طريق المحافظات تعميمه، والمجتمع يعرف هذا الشيء. برجع للزميلات الدكتورة ناهد والدكتورة خولة، وما تبقى لنا من وقت، ما أعرف أسماء كم وقت؟ 10 دقائق. طيب إذن نوزع 10 دقائق بإذن الله ما بينكم. صاحبة السمو الدكتورة خولة في دقيقتين الله يحفظك، ويش رسالتك كون إن احنا بإذن الله في جلسة مفتوحة يعني المجتمع العماني يسمعنا؟ تفضلي في هذا الجانب.
أولاً صحة الأطفال في إيد كل حد يتعامل بالطفل، سواء طبيب، ممرض، أمانة. أيوة، ولازم نأديها على أفضل وجه. وإحنا يعني بشكل عام ما ننتظر لحد مشاكل تصير، مفروض نبتدي بالتوعية الأول والحماية منها، فهذا دورنا دائما. وحتى لو مثلا أعرف كثير من هنا في أطباء يجي الطفل في زيارة لموضوع ما، نقول التهاب رئوي، هذا الوقت اللي بعد الواحد ممكن يوعي فيه، لأنه بعض هذه المشاهد والسلوكيات نشوفها بنفسنا. والأهالي ما أعتقد أنهم هم بشكل عام ما يريدوا الصحة والعافية لعيالهم، بس لأنهم ما يدركوا أبعاد هذا المواضيع. بس إحنا كعاملين صحيين نعرف هذه المخاطر، وعلينا أنه دائما نوعيهم عشان مصلحة الطفل في النهاية.
بارك الله فيكي. وأختي القديرة دكتورة ناهد، يعني فترة المراهقة ما أحلاها، ومعانا هنا مدراء مستشفيات أكيد من كل المحافظات، فرسالتك ليهم للمراهقين، كونك أنت ما شاء الله تقودي طب المراهقين معانا، تفضلي، رسالتك واضحة إيش ليهم؟
أول شيء رسالتي لكم كأهل، يعني دائما بتبدا من البيت. يعني هو قبل ما يروح ويصير بعمر المدرسه ونحط مسؤوليه على المدرسه، او يمرض ويجي عند الطبيب، المسؤوليه بتبدا منا نحن كاهل. من بعد ما نحن كأهل بتروح على الطبيب، حتى قبل ما يوصل على السكول، قبل ما يصير بسكول ايج، لما بيجي لعنا يعني حتى التوصيات انه مثل ما بنسالهم بياكل، كيف بيشرب، عم بينام، عم بيزيد وزنه، ما عم بيزيد وزنه. انا عم بحكي بالاعمار الصغيره وحتى بعمر المراهقه، ممكن سؤالين بتقريبا 30 seconds من اي اسسمنت عم نعملها لمراهق، انه نسال عن استخدامه للاجهزه الالكترونيه، هل في نظام بالبيت متبعينه، نكرس فكره انه، وهيدي كثير انا يعني بصمم عليها لكل الاهل، انه فري زونز بالبيت without screens، يعني ما يكون في، يعني غرف النوم ما فيها تي في، ما فيها كونسولز للفيديو جيمينج، وتكون محل اللي بدهم يلعبوا فيها الالعاب الالكترونيه هاي ترافيك اريا بالبيت، يعني بالكوريدور الكونكتر اللي بيروح على كل الرومز، غير لما أن يكون بغرفته. للسكولز انه نشجع على المواطنه الرقميه او الديجيتال سيتيزنشيب، نبدا بكلتشر اوف انه نعلمهم من هن وصغار كيف يكونوا سيف اونلاين، مثل ما بنعلمهم كيف يكونوا سيف بالحياه الواقعيه. ولا طبعا التشريعات، يكون في قوانين لنعاقب الاشخاص اللي ممكن يتعرضوا لسايبر بولينج وسايبر ستوكينج للمراهقين، بالاضافه ل يعني هيئه الاتصالات والشركات الاتصالات in every country، وهون عندنا بعمان يكون عندهم رقابة على المحتوى وعلى البلاتفورمز اللي بيجيبوا لنا إياها على بلادنا وعلى بيوتنا.
أنتي دكتورة، وصدقوني ما أحلاها، وتواصلوا معاها. أنا أول وحدة بتواصل معاكي. بالنسبة ملكة، ومن سماكي ملكة ما شاء الله عليها، إيش رسالتك للمديريات، مديريات وزارة التنمية الاجتماعية في المحافظات؟ تو انتي خبريهم، هذول مدراء مستشفيات، لو لا قدر الله جات عندهم حالات بسبب الاستخدام الغير رشيد للأجهزة الذكية، كيف يتواصلوا مع الدوائر مالكم في المحافظات؟ ايش ارقامكم؟ كيف يوصلوا لكم؟ آلية الإبلاغ؟
طبعا آلية الإبلاغ هو الخط الساخن على خط حماية الطفل اللي هو 1100 1555. رسالتي للمجتمع خلق توازن ما بين الواقع الرقمي والواقع، خلق توازن ما بين الوقت الرقمي والواقع، خلق توازن ما بين الوقت الرقمي والواقعي. وكذلك أيضا مثل ما ذكرت الدكتورة خولة، لو المجتمع استمر على هذا النهج، إنه الأطفال من أقل من عمر 2 ممنوع استخدام وسائل التواصل الاجتماعي، ومن عمر 5 سنوات فما أكثر لمدة ساعة واحدة في اليوم، لو وصلنا لهذا المجتمع إنه الكل التزم بهذا الشيء، إن شاء الله يعني بنحصل الخطورة أقل من وسائل التواصل الاجتماعي، وكذلك أيضا التأثيرات بتكون أقل في المجتمع.
أحسنتي. دكتور طارق، يعني أنا اليوم رحمتك 4 حريم، وكلوا الجو عليك. يعني أنت ما شاء الله يعني ما قصرت، بارك الله فيك وبيض الله وجهك. لكن نبي نسمع الدكتور طارق، مش الاستشاري، الأب، ومن دولة عزيزة علينا في هذا الجانب. إيش رسائلك لزملائك؟ ونختم.
احنا بدينا اليوم الصباح بالثقافة، ثقافة السلامة، وأتوقع أنه ثقافة الاستخدام المفرط الجوالات أو الأجهزة. أتوقع أنه نحتاج نشتغل كثير على ثقافة المجتمع، كيف نغير ثقافة المجتمع وكيف نعلمهم من الاستخدام الآمن للأجهزة. اللي قاعد يصير الحين ثورة، وهي ثورة يعني لها مفاسد كثيرة. زي ما تفضل منعها ما راح تمنع الأجهزة من دخولها، لكن إنه لازم ثقافة المجتمع. عاتق كبير جدا على العائلة. للأسف اللي قاعد يصير الحين إنه بالذات يمكن في مجتمعاتنا الخليجية، أنا لازم أجيب ولدي جوال ولا بنتي ولا هذا، لأن ولد أختي ولا ولد خالي ولا ولد عمي معهم بنفس العمر لازم أجيب لهم شيء. هذا الثقافة هذه هي اللي راح تعدم المجتمع. أتوقع هي الثقافة ثم الثقافة ثم الثقافة. العائلة لهم دور كبير، المجتمع له دور كبير. المجتمع اللي قاعد يصير الآن من ندوة هذه جميلة، يجب أنها يعني يشارك فيها عدد أكبر، تعاد مرات ومرات أخرى. المدرسة لازم يكون لها دور كبير. المدرسة لازم تقيم، يعني حتى على المراهقين لازم تقيم المدرسة دورات ورش عمل تقام في وسط المدرسة للطلاب والطالبات، يعني بحيث أنهم يكونون جزء من المشكلة. يعني احنا الآن قاعدين نناقش الموضوع، لكن أنه الناس الفئة لازم تحضر الفئة، لازم نسمع من الشباب والبنات اللي في عمر المراهقة، لازم نسمع منهم. الآن الأجيال الحديثة غير أجيال اللي احنا نسميهم الديناصورات.
الديناصورات.
أجيال الآن، الأجيال الشباب هذول والبنات جيل ذكي، جيل يفهم، جيل يعني ما يمكن، لازم تقنعوا بالشيء. إذا ما أقنعتوا في الشيء ما راح يسمع لك. فالثقافة، المجتمع، المدرسة، كلهم لهم دور يعني. وبالأخير عاد إن شاء الله ما نصل إلى الشؤون الاجتماعية، وهذا نبي نحاول نمنع قبل الوصول إليها. يعطيكم العافية.
نتفق جميعا بأن يعني هنالك غزو عالمي تكنولوجي، ليس علينا فقط يعني في عمان أو في الخليج، وإنما هذا شيء عالمي. أمس أو أول أمس قاعدة سبحان الله أقرأ إنه في إصدار لي I don't want to advocate للشركة التليفون، لكنه تصدقوا قبل أن يطلعوا الجهاز الذكي هذاك من الشركة المنتجة ملايين الناس تنتظر برا. عرفتوا ويش؟ وأتوقع حتى هنا معانا للأسف الشديد. نتفق جميعا بأن هنالك غزو تكنولوجي، نتفق جميعا بأهمية السيطرة على هذا الشيء، وأنه ضروري أنه يكون بالمسار الصحيح. نحن يمكن متلقين وزارة الصحة، وزارة التنمية، الجمعيات الأهلية، يبدأ الدور الأساسي دور الأسرة. دكتور طارق، ملكة، دكتورة ناهد، صاحبة السمو، الدكتورة خولة، تقبلوا مروري جميعا ودمتم بخير.
شكرا جزيلا دكتورة فنا، شكرا صاحبة السمو دكتور خالد، الأخت ملكة ودكتور ناهد، شكرا جزيلا على هذه الجلسة المثمرة. أتمنى من الجميع يكونوا استفادوا. أكيد الحضور يمكن عندهم أسئلة بس بنخليها إن شاء الله على نهاية السيشن. أنتقل الآن إلى ضيفي الكريم next speaker دكتور محمد عدنان، شرفنا من دولة قطر. شكرا جزيلا على حضورك اليوم وننتظر إن شاء الله محاضرتك. Dr. Muhammad is a senior consultant in pediatric neonatology at Women Wellness and Research Center, which is part of Hamad Medical Corporation. He also serves as an assistant professor in pediatrics in Weill Cornell Medicine, Qatar, and assistant professor of neonatology at Qatar University. He completed his medical degree and pediatric residency training in Syria before joining Hamad Medical Corporation in 2002. He completed his fellowship in neonatology in 2011. He followed by the Institution of Healthcare Improvement, IHI, Quality Improvement and Patient Safety Fellowship in 2015. He works as an attendant neonatologist in the Neonatal Intensive Care Unit at the Women Wellness and Research Center, where he leads quality and patient safety initiatives. In addition, he is a faculty member at Hamad Healthcare Quality Institution, where he teaches quality and patient safety to HMC staff. Thank you, Dr. Muhammad Adnan. Welcome.
السلام عليكم ورحمة الله وبركاته. طبعا في البداية ممكن أحكي بالعربي وبقول إنه أنا سعيد جدا إنه أكون في سلطنة عمان الحبيبة. طبعا أنا جاي من قطر وأكيد حأنقل بعض الإكسبيرينس من دولة قطر يلي نحن عم نقوم فيها في مجال الرعاية الآمنة للمواليد، وأكيد لا أخذ كتير من هذا المؤتمر على دولة قطر، وإن شاء الله هأخذها بعدين على بلدي سوريا بإذن الله. So I will talk today about safe care for every newborn, global best practice and their relevance to Qatar's health system. So my objective today will be identifying key global challenges affecting the safety and well-being in newborn, and we will highlight the evidence-based safety practice currently implemented within Qatar healthcare system, and proposing actionable solution to enhance progress and foster continuous development in neonatal care. So every newborn deserves a safe start of life. Either this newborn, he will stay with his mother, or he will be admitted for any reason to intensive care units. So safe newborn is the cornerstone, because this newborn, he will be in the future an individuals. And if we will provide safe care, it will be crucial and it will be good for the lifetime and good health and development and productivity in the future. We know if the care system are not safe and reliable, any small error will lead to fatal consequence. And this is really will be very important for a neonate, because a newborn, we know he will have this, what we call it, a transition from intrauterine to extrauterine life. And he will be very fragile during this period. So also the neonate, he had immature in all his organs. So he needs sometimes support for brain, for lung, and the most important also for his immune system. So he is vulnerable for risk of infection and poor temperature regulation. And this is the reason the mortality and the morbidity will be very high in the first 25 days of life. So as they mentioned from our colleague, we have more than 6,300 newborn die every day in low and middle income country. And unfortunately, most of these cases is preventable. So that's mean really we need to work more to make more safe for our neonates. So why it's happening? Because there is a lot of burden, a lot of gap in many health systems. So if we will start, because most of the low-income country, middle-income country, they don't have the infrastructure for in ICUs. Even for the health care, who should start from beginning, even before marriage and during pregnancy, during delivery and after delivery, how to take care of this neonate. So most of these challenges, it will be not availability of NICUs and equipment. We have sometimes shortage in staff trained for neonatal intensive care units. But the most important part, it is the safety and the quality. So sometimes unsafe follow-up in pregnancy will lead to really very bad outcome, or some acquired infection in the hospital, medication error, lack of standardized safety protocol. All this will lead to very bad outcome for the neonate. So what we should do for that? So in state of Qatar, the national health strategy is funded on principle of delivering comprehensive health care for all residents. This care is designed to be easily accessible and highly effective and aligned with the highest international standard. It emphasizes quality, safety, and patient-centered approach. So what system they implemented in Qatar for this? If we will go for this one, we will start from the pregnancy. So even for the pregnancy, it is starting from pre-marital medical care to do testing before marriage to reduce the genetic disease that may cause serious illness for the newborn. During the pregnancy, there is very good established system for the safe delivery. So they established in all hospitals there is very good equipment and for monitoring for the delivering ladies and fetus. So they will monitor during the delivery. There is provided trained staff to perform the delivery and the cesarean section in all labor room. And also we have in all facility trained staff for doing the resuscitation for the baby in case they need this resuscitation. And all staff working in all women's hospital and delivery section, they are certified by neonatal resuscitation program. And all with this one, it's really improved the survival rate after birth. So what the initiative also they started with the kangaroo care, and it is starting from the delivery room. So the baby after delivery, immediately it will be given to the mother for kangaroo care, which stabilize the temperature and will increase the bonding between the parents and the child. And also, they will start exclusive breastfeeding. Also, this one will provide good nutrition for the baby and will decrease the infection. Now, if the baby, he is okay and he will go with mother, so how we will make this baby safe? So we implemented what we call it Qatar Neonatal Warning System program. So this is a program to detect any abnormal signs, and there is a proper response for this one. What we are doing also, we are doing education for the parents to recognize early any warning signs, and either the baby still in the hospital or after discharge, and this is really helpful to recognize early any deterioration for any baby. All newborn will be examined by trained physician, and Qatar implemented 3 screening program. The first program was the metabolic screening program, now about 20 years, and it will be detecting more than 30 metabolic disease. And we implemented also a program for screening for cyanotic congenital heart disease, and also the third one for the hearing. All baby will receive the vaccination before discharge, and they will have follow-up in the baby clinic in the health care, so they will be followed and they will be monitored for the developmental and for the growth. So this is if the baby he is okay and kept with mother. But what about really the baby admitted to the NICU? So as I am really giving lectures for safety and patient safety, always I will say what since decades and since Hammurabi and Ibn Sina and even Hippocrates, they said, if you cannot help the patient, please don't do harm. This is very important. So this is really what we are doing to decrease any harm it will be affecting our patient. So what we did in our NICUs to make our NICU more safe. So we did a huge number of initiatives. First one, it will be, I am mentioning here about the infection prevention standard. So we implemented the Safe Hands project according to the WHO. So it will be in a place for all NICUs. We implemented what we called aim for zero CLABSI or central line associated infection. We implemented a project for decrease late onset sepsis or the acquired infection in the hospital. And the first antibiotic will be prescribed and administered to the baby within less than 1 hour in case the baby he had any deterioration. And we have timely announce of the blood culture result. And if the baby doesn't have any infection, we will stop the antibiotic. And this is also for the antimicrobial stewardship. So this is for the infection prevention. And as you know, in the NICU, the baby will have like a lot of mechanical ventilation issues and other problems. So again, we have many projects for the mechanical ventilation, as Dr. Tariq, he mentioned about unplanned extubation. To stop unplanned extubation, this is really, and we now we are really getting very, very low benchmark for this one, and also to reduce the neonatal pneumothorax, and to reduce the any nasal injury or any skin injury when we are applying non-invasive ventilation. Again, the most important part with the medication safety protocol. So we initiated a lot of protocols now and initiatives, especially when we implemented the electronic record system. And now we have a very good established system for a strict dosing and double check system in place. So now really we have very low incidence of medication errors. The third one, I want to talk about it, and again, this is mentioned by Dr. Tariq, about the involvement of the parents in the care of the baby or care of the child. So our facility accredited maybe a few months back with what called person-centered care. And this one, it is about how really we can make the parents involved during the stay of the baby. So now, even they implemented this even from the delivery room. So now the mother, she can choose who will stay with her even during the delivery, her husband or what she wants to be. And in our NICU, the mother, she is now taking care of the baby. She can do some of the nurse job, like giving feeding, changing the diaper, or doing a lot of things, taking care, and also even monitoring her baby. There is what we call shared decision making. So any decision will be for the neonate will be shared with the parents, and open visiting hours, and they have also access to the medical record. We are promoting the comfort through the maternal engagement, and also we have a going home safely project. So now the parents will be educated before going home. They will be educated about even the how to do CPR for the baby after discharge if anything happening, and also they will be aware in what case they need to visit the pediatric emergency and what the signs. All this one, it will be in a place. The last things I want to mention here, what we call for the premature baby, because this is what they need really very good attention. And most of the mortality and morbidity in the NICU, it's coming from these premature babies. So we have in our facility what we call it tiny baby unit. It is about 28 beds. This is only for premature baby below 28 weeks. And what we implemented so far now, we implemented Golden Hour project. So Golden Hour project, it will be taking care of this baby below 28 weeks in the first hour of life. So we have a trained staff. They will do the resuscitation. They will provide the better respiratory support for the baby, maintain thermoregulation, normoglycemia, and timely IV antibiotic, and also for implementing the delay cord clamping. We have IVH prevention bundle and Crohn, which is the cranial modeling for an NICU baby to prevent any head deformity. So this is what we did so far in our NICU. So what we can do in the future. So now really we should go for modernized healthcare system with advanced NICUs. We need to invest in the capacity building for neonatal nurse and doctor. And we should adopt WHO patient safety protocols universally. We ensure equitable access to safe and quality neonatal care in all regions. And we will expand neonatal expertise through the telemedicine. We should have time to call for action now. So we need to really practice zero tolerance for unsafe care. We need to recognize newborn safety as a fundamental right. Prioritize patient safety in all national health strategy. Promote culture of safety in hospital and delivery wards. Engage families as safety partner, and commit for lifelong learning and quality improvement, and strengthen the international collaboration to share knowledge. Our conclusion, safe care is not optional. It is a human right. We are, as United Global Action, together we should to pledge to make safety the cornerstone of a newborn care, because every newborn matters and every life counts. Thank you.
Thank you, Dr. Mohammed Adnan. We will move now next to our next speaker, Dr. Manoj. Yes. Dr. Manoj has a fellowship in neonatology from Canada and Australia. He's a senior consultant in neonatologist. He is currently working in the Medical City of Military and Secretary Service, and he has many publications, around 21 publications in peer-reviewed journals, so many other papers, authors of 4 chapters. He's also a member in Antibiotic Stewardship Committee. Welcome, Dr. Manoj. Thank you. Dr. Manoj also is he's an ex-chairperson in ASP and a committee member in researches QI, ICU, mortality and morbidity at Khawla Hospital, and also has areas of interest in antibiotic stewardship, quality improvement methodology, and implementation science. Welcome, Dr.
Good afternoon and salam alaikum, everyone. First of all, I would like to express my sincere appreciation to the organizing committee for acknowledging our work and giving me this wonderful opportunity to express and show our study. Hello, am I clear? Okay. So this was our study is a qualitative thematic analysis of barrier and facilitator in implementing a national antimicrobial stewardship program in 7 neonatal intensive care unit. So this was performed under the umbrella of Director General of Infection Control and Disease Surveillance, that's called DIS of Oman. And I would like to acknowledge this study involved so many people, and so many people's insight and wisdom was there from 7 neonatal intensive care unit, from Ibri, Ibra, Khawla, Nizwa, Sur, Suhar, and Rustaq. So I'm really thankful to all the neonatologists, all the antibiotic stewardship committee from this hospital. And their contribution has tremendously contributed in improving the antibiotic prescription behavior and morbidity and mortality. This was a part of a study of implementation of antibiotic stewardship in this 7 NICU unit. So as we know that overuse and misuse of antibiotics are very common all over the world. 45 to 70% of NICU admission in some cases in some country, almost like 80 to 90, 100% of all babies admitted to NICU receive antibiotic. And out of that, 40 to 70% of it is inappropriate antibiotic use. These are not indicated, but issues because of various factors. So I think we are in the era of post-antibiotic apocalypse. That means where the common illnesses become the life-threatening again. And resistant microorganism is the biggest threat to humanity now. And this is increasing morbidity and mortality. Sometimes the patients are admitted for myocardial infarction, but are dying because of gram-negative infection. You are admitted for a hip replacement, but the morbidity is increased because of SSI, surgical site infection. So it's increasing the hospital stay and also cost. And it is, antibiotics are one of the limited resources. So since last 10 years when I was in Kaula Hospital with Dr. Muhammad and Dr. Salima, we implemented antibiotic stewardship program in 2014, and it's almost like 10 years of experience, and we showed more than 50% reduction in antibiotic usage and published in Journal of Perinatology. And so after this program, we are under the umbrella of, as I said, Director of Infection Surveillance and Control Desk, this project of implementing antibiotic stewardship was started in 2024. So this is the baseline data, and it showed a significant variability. The data of more than 25,000 infants across 7 neonatal intensive care units, and as you can see, 45% of the babies received antibiotic during their stay in NICU. And out of that, there was a significant variability. From one unit received 23% to the other unit up to 75% of antibiotic. So the objective, this was a part of that study to analyze, to examine the qualitative themes regarding the barriers and the facilitators of the implementation of antibiotic stewardship. This team and the neonatologist, Dr. Muhammad, myself and other were involved, and we visited each unit, stayed there for 7 days, and did a personal interaction and hand-on experience with this 7 NICU. A discussion with the antibiotic stewardship committee, a local neonatologist, microbiologist, infection control, pharmacist, and neonatal nurses was carried out. A hand-on training was implemented. A discussion on antibiotic stewardship was initiated and implemented. A quality theme analysis based on CDC core value of antibiotic stewardship was performed. Under this heading, hospital leadership commitment, we looked into the accountability, looked into the availability of the pharmacy and infection control experts. We look into what are the antibiotic stewardship action are followed, whether there is any antibiotic stewardship consumes are measured and feedback was reported or not, and what sort of antibiotic stewardship education is performed. So the most important, the facilitator we found is that the organizational commitment is the key to the success of antibiotic stewardship. And we found that secure, visible commitment from the hospital was present in all the 7 NICU. However, the multiple disciplinary hospital antibiotic stewardship was present at variable levels in different NICU. Most of the hospital had an antibiotic stewardship committee, but the implementation was variable. And the specific neonatal NICU antibiotic stewardship policy was present only in 3 hospitals, 3 NICUs. Another facilitators which we found is definite roles and responsibility, which was well defined about each and every stakeholders in antibiotic stewardship committee and other frontline workers. The most important thing is if you have got a good infection control policy, that will decrease your antibiotic usage. So presence of infection control, nursings and department and implementation plays a huge role as a facilitator. Microbiology lab support, particularly in presence of diagnostic uncertainty, plays a huge role as a facilitator, and it was present but not fully utilized in all NICU. Technology and data, particularly surveillance system, utilizing laboratory and pharmaceutical data to track the antibiotic consumption. Antibiotic consumption tracking was available in almost all hospitals, but was not utilized and was not aware by all the neonatologists and the frontline health worker. Audit and feedback, that's a very important part which plays a huge role in appropriate antibiotic utilization. To use data to provide a regular feedback to the prescriber on their antibiotic usage pattern was not very, is a facilitator but not present in, were not present in all the NICUs. Basic knowledge about the antibiotic usage, its risks and advantages, and engaging this with the end users really plays a huge role in curbing the antibiotic use, and that acts as a facilitator. Now, major barrier what we found is the lack of NICU specific antibiotic policy, which was not there. It was there wherever there were, but not implemented in all NICU. Lack of resources was another issue. There was lack of staff, nursing staff, a lack of trained antibiotic stewardship personnel. In some hospital, lack of resources, particularly the consumables like blood culture bottles was not there. So antibiotic was started without taking the cultures. Other barrier is, I think, the competing priorities. I think antibiotic stewardship is put on the back burner because too busy with the clinical works, and clinical workload is on the high priority with the less staff, plays a huge role, barrier in implementing antibiotic stewardship program. Lack of data-driven decision making also, there is no opportunity to improve that whether you are doing good or bad. There was no accountability in all the NICU. Some of them were very good, some of them are moderate, and some there it was lacking. The major barrier is the culture and habit, culture or unit culture, as previous speaker has mentioned, that plays a huge role in safety and implementation of antibiotic stewardship program. I think change or habit change is a violence. I think sometimes it really creates a problem among the different human behavior. I think antibiotic is considered to be a benign. Most of the neonatologists or pediatricians feel that it's a benign decision. I think, okay, when asked how many days you want to give, okay, give 5 days or 7 days and all, without much of evidence behind it. And that's why it becomes very difficult to implement, and implementation is slow. Other thing is there are sometimes you face with alpha male and alpha female which are resistant to change. They carry so strong value about it and personal biases, and that will inhibit. Alpha male and alpha female. Nah? I think if you have a dog in house, so whosoever is prominent, the dog will go to that person only. So there are, in every unit, there are alpha male and alpha female. So if you really want to implement antibiotic stewardship, you need to convince that person, and you take that person into your fold. Most of the time, in particularly the socialistic system, where the responsibility is shared, most of the frontline feel that this is not our responsibility. If there is any resistance, bacterial infection, they will say call the microbiologist or call the infection control. But they will not do introspection. So that is a major barrier in implementing this type of, so it's more of a behavior issue. And the lack of targeted education is also the antibiotic stewardship, awareness about the risk and benefit is sometimes lacking, and that may be a reason for overuse of antibiotic. So I think I will conclude that because I thought it's only 10 minutes, so that's why I just, I don't know, I took 11 minutes. Our study highlights the key facilitator and barriers of implementation of antibiotic stewardship in NICU. I think to improve antibiotic stewardship prescription and effectiveness, you need to develop an educational program. You need to enhance the resource allocation. That is major issue in some of the NICU. It's antibiotic stewardship is a back burner. You need to make awareness and education. And there is a need to foster the collaborative culture among the various healthcare providers. I think recently I came back 2 days back from Canada, and I visited this Banff, where there was a museum of how we can protect Earth for the next generation, and they were taking photographs. So I put to myself that optimum utilization of the resources is very important to save this Earth, and resources belong to all the species. An antibiotic is a scarce resource. We should save it. Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I want to thank everyone who's until now awake and standing with us. And I want to thank Dr. Manoj for this enlightening presentation. And one comment about the infections and hospital-acquired infection, I would like to comment that if we don't use the antibiotic in a wisely manner, we will be seeing more and more resistant bugs in the hospital, especially in the ICU. And this is what have been seen the last, I can say, a few weeks or few months, where we have more and more acquired resistant bugs in the hospital. For this session, we have 3 speakers, and I would like just to حذر, and please try to keep the time so that you can go for lunch as quickly as possible. We'll start with the first speaker, Dr. Saeed Lushi. Dr. Saeed, طبعا one of, I don't want to say أنا ديناصورة, but one of our residents he was with us in the OMSB program. He is now currently an neonatologist at Sohar Hospital, and he is the head of the NICU at Sohar since January 2023. As I said, that he was an OMSB resident or graduated in 2018, and he's a member of MRCPCH. He had his certificate in 2018. He is as well, he was trained for his fellowship at the McMaster University, and he came back and joined Sohar Hospital in 2022. And he is an American Heart Association mentor for Neonatal Resuscitation Program in Oman. Today, he's going to talk about quality improvement initiative to rescue neonatal late onset infection and CLAPSI at Sohar Hospital. Please welcome Dr. Saeed, and please enjoy his talk.
Thank you, Dr. Saad, for your introduction. And Assalamu alaikum. Good morning or good afternoon now. I think all of you are sleepy now, but we'll make it short, inshallah. So, good morning, or I want you to be awake. So that's why I repeated good morning, good morning. We are afternoon now. So, good afternoon, my colleagues. Good afternoon, our healthcare profession. Good afternoon, everyone. So, before I start my talk, so I would like to say one thing here. We are all here today. It is not just to celebrate the day or to show our numbers, our statistics, or to share our projects between colleagues. We are here because we have a belief, we have a culture, we have a commitment to this country that every baby, every newborn, every child, patient safety is the priority. And the safety or the safe care of every baby or every child is more than the protocols, checklists, studies, quality improvement initiatives, or bundles. It is more of culture, as Dr. Tariq said, and it is a commitment, and it is a shared, continuous responsibilities between the healthcare providers, the families, and the society. So thank you for inviting me to be here today, and together we can share also some of our improvement action in some area of improvement in our unit. It is my privilege also to stand here in front of you to share our project, which is a journey to zero. So from its name, it's a journey. A journey means months and years. So it is not a simple method or a simple study. This project lasted for 40 years until we achieve our results. So it is also in one of the most critical aspects in the newborn care, which is infection. Infection, infection, infection. In the intensive care, sometimes I can help the babies to go home for whatever reason, respiratory, cardiovascular, brain, whatever, I may help these babies to go home. But when it comes to the infection, especially hospital-acquired infection, sometimes I am helpless. I cannot help this baby to go home. And it carries a lot of risk of mortality, morbidity, and long-term also poor outcome later on with these babies when they get infected from our hospital, or what you call it as hospital-acquired infection. So this is the aim of our study, which is a quality improvement initiative to reduce neonatal late onset infection, central line associated bloodstream infection. You will hear in my talk, CLABSI, CLABSI. CLABSI means central line associated bloodstream infection. It is a journey to zero. Zero means we achieve zero. And it also reflects that our team at Suhar Hospital, also they are working on the patient safety. They are working on how to make the place, the intensive care, the NICU, is a safe place for every baby. The background, as we know, neonates are considered immunocompromised because they have immature immune system, because they have prematurity, because of prolonged hospitalizations, and because of the need of frequent invasive also procedure like central line for nutrition and medications. Hospital-acquired infection, which means the infection that happens after 72 hours of life in a unit, which is typically hospital-acquired infection. So stop the time, huh? Stop the time. I want to move there. Now it's working. So hospital-acquired infection, it is the infection that happens after 72 hours of life in newborn, which is typically hospital-acquired infection, we call it. CLABSI is the one of the most common hospital-acquired infection in neonatal intensive care unit, which can lead to significant morbidity, mortality, and impaired neurodevelopmental outcome, and it may increase also the length of stay in the NICU. Suhar Hospital, do you hear me well? Okay. Suhar Hospital is one of the biggest public hospital in Sultanate of Oman. It's serving the north of Oman, and according to Omani National Center for Statistics and Information, it has the highest rate of newborn deliveries in Sultanate of Oman, which is about 1,000 babies per month, 12,000 babies per year. And our neonatal intensive care is at tertiary level, and also it has 48 beds capacities with high rate of admission, which is about 900 babies per year. And we have also sick patients admitted in our neonatal intensive care, like extreme premature baby, post-surgical babies, and transferring baby from other hospital. According also to our local hospital statistics and the infection control also numbers in 2022, the total number of admission were 906 babies at Suhar in NICU. 450 of these were preterm less than 32 weeks. which around 50% of total admissions, and there were 45 deaths. Out of these 45, 21 of these deaths were preterm baby less than 32 weeks, and 12 out of 21 of preterm, they died because of CLABSI and central line associated bloodstream infection, late onset infection. So if you look at this graph, you will see that the causes of death in preterm less than 32 at Suhar in 2022, CLABSI was the most common cause. It was more than 50% of the preterm died because of CLABSI. In addition, we compare also our statistics in 2022 to the international statistics. And the incidence at Suhar NICU at that time was 25 per 1,000 central line days, and which is significant high comparing to the international CLABSI rate, which is around 3.5 per 1,000 central line days in developed countries. However, CLABSI rate also it's ranging between 2.6 to 40 per 1,000 central line days in developing countries like Oman, and the average is around 11.8 per 1,000 central line days. Sultanate of Oman is one of the developing countries in the Middle East. Unfortunately, we have no national standardized NICU care policy for infection. We are working now to make our also neonatology, Omani Neonatology Society. In addition, also our national data on CLABSI rate is lacking in most of our centers in Oman. So, based on these statistics and based on the causes of death in our NICU, we found that the CLABSI and the CLABSI-related late onset infection was the most common cause of death in preterm babies in 2022 at Suhar Hospital. Therefore, the prevention of this CLABSI and CLABSI late onset infection is essential to improve the outcome and the survival of our NICU babies. And based on the literature, if you go to the literature, you will find a lot of meta-analysis. You will find a lot of large multi-center studies. And they have also shown a lot of significant result reduction from CLABSI rate, from late onset infection, ranging between 50 to 70%. And there are some units also, they are achieving zero CLABSI rate for almost years or days. So that's why we thought about doing a quality improvement and to address this measurement of this problem, implemented steps to reduce the hospital-acquired infection rate CLABSI at Suhar Hospital, and then to sustain the result that we achieve. So it is quality improvement initiative project, and it has a SMART goal. It is specific to reduce the rate of CLABSI, and by reducing the rate of CLABSI, we reduce the late onset infection rate in the NICU. Measurable, our aim was at the beginning to reduce the CLABSI rate, late onset infection amongst neonates by 25% over a year, and more than 75% over 2 years, with ultimate at least to celebrate 1 month of CLABSI zero and 6 months of CLABSI-related death in our unit. This is our aim from the beginning. Achievable by implementing auditing evidence-based interventions based on our literature review, relevant to improve the neonatal survival and outcome, and the timing was between January 2020 and until December 2025. Still, we have 2 months left. But I came here with the results. So this is the quality improvement, and before we start any quality initiative project, we have to create our root cause analysis why we were having high rates of CLABSI and late onset infection. And this is summarize the fishbone diagram in our unit. So we have 4 B's: people, place, policy, and the central line. And based on this fishbone analysis, we have implemented the steps, the components that we are going to see now in the coming slides, and also auditing these steps. So after literature search for proven interventions for reduction of neonatal CLABSI and late onset infection, we have 6 components. And these are the 6 components we worked on in our project. The hand hygiene, strict on the hand hygiene. we started also our guideline policies about the early onset sepsis, late onset sepsis, restriction of using antibiotics. And usually the overuse of antibiotics will lead to more infection. As Dr. Suad, Dr. Manouj said, central line bundle, NICU structure. Basically, Suhar Hospital was level 2 in ICU, and it was called Special Care Baby Unit. But with this expansion, we thought how we can create it more safe for like level 1 in ICU for our babies, because now we are receiving also extreme preterm babies and also post-surgical babies. Using of breastfeeding and standardized also feeding protocol and the surface swabs. These are the 6 components, and each component has also a reference from where we also brought these also components. Strict hand hygiene, I will just highlight the important points. I think all of you are familiar with this point. I will just highlight the important point. In the strict hand hygiene, what we have done, differently, we started a routine hand hygiene for all hospital care providers, who are those who are working in the ICU or those who are visiting us from other subspecialties. Also, we implement also strict hand hygiene for families. So any member of the family, father or mother, enters the NICU should also have strict hand hygiene. We have now monthly repeated reminder and surveillance about the compliance about the hand hygiene. Stewardship, improving the use of antibiotics. We made our antibiogram. We found our microorganisms. We started also selection of antibiotics. We have created our early onset, late onset policy in 2023. We are working 6 monthly to review our policies. Is there anything else? I will give you one missing, maybe it's important for the healthcare provider, that before 2023, the second line of antibiotic, we use cefotaxime. But based on our antibiogram, it was resistant to all the organisms that we see in the late onset infection. So it was useless to start cefotaxime. So we changed our policy based on our antibiogram. Now, based on our auditing, we found now there are some organisms, now they are susceptible to cefotaxime. Why? Because we restrict use of cefotaxime. So this is very important. Antibiotic is very important. Central line bundle, it's very important. It has also a lot of points here. Maybe you may not also think about it, but it's very important. And every morning round, you should ask yourself, do I need that line or not? I think there are some centers, they use central lines until the baby tolerates the full feed. We stopped that, process, because we found 1 day more with central line, it means more infection for these babies, especially in the crowded areas. We have crowded patients. So we thought about once the baby tolerates like 120 ml per kg per day, we remove the central line, we put BIV, less risk of infection, which is working with us also. It has a lot of things there. Also the BIV has to be changed, a lot of things there. It is a minor, but if you go to the literature, you will find a lot of positive results, how you can decrease your collapse rate. In ICU structures, also there are some areas of improvement that we created. There were a lot of things. And actually, Dr. Tariq, in this NICU structure, I guess adopted from Saudi policy about the NICU structure, infection care, the distance between baby, and there are a lot of things in Saudi policy of the NICU infection. Breastfeeding feeding protocol. Before 2023, we didn't have feeding protocol. Everyone has his own protocol. That's why there was a delay in initiating the feed. There was a delay in also establishing full feed. So now with centralized feeding protocol, also there is less time to keep this baby on central lines. Mandatory swabs for all admitted babies, because we found sometimes mothers are admitted in the maternity, in the gynae ward, and they come with colonization, and their babies are colonized, which is a source of infection in our unit for outbreak. We had 2 outbreaks in 2023 and 2024 because of mother colonized. We had 3 phases of data collection. I will go fast because of the time. The first phase, it was pre-implantation. This is the period when we had these high numbers of collapse, high rates of also deaths. It was between January 2022 until December 2023. We started the first implementation transition phase in the first 6 months of 2024, and now in the post-implementation phase. Main outcome, to measure the CLABSI rate, the CLABSI late onset infection-related mortality pre and post interventions, and the definition of CLABSI, the definition of CLABSI rate, whatever we brought it also from CDC, and we use our statistical analysis based on the result. So let us go to the last 2 slides, which is very highlighting points here. This is the results. So based on these 6 components, what we have achieved. If you look at the numbers of this is the CLABSI events, the number of events of CLABSI in 2022, there were 48 events. There were 48 babies with CLABSI. In 2023, there were 44. In 2024, there were 29. In 2025, until now, we have only 7. Also, we have created a reference chart for the CLABSI rate per 1,000 central line days. And if you look, the blue line is the line of the 3 monthly central line rate per 1,000 days. And if you see from 2022, the beginning of 2022 until now, you see the line is coming down. And in regards to the deaths, which was the striking point for us in 2022, we are where we are now. 0. And this is the journey of 0. So it's a journey of 0. And again, the whole message here, when you want to initiate a process, it is not overnight process. No. It is long journey. You need to be patient. At the same time, you need in between to stop and audit, and again, this is the BDCA cycle. Overall, there have been also significant improvement in the compliance with these protocols. Alhamdulillah, our aim was to achieve 10 CLABSI month, but we have achieved 5 months of CLABSI 0. And our aim was to achieve half year of CLABSI 0 or related death. And until now, we have 1 year of 0 CLABSI related death, which is a big achievement for us at Suhar Hospital. So based on this result, this quality improvement initiative project also showed significantly reduced the late onset infection, CLABSI rate, and their associated mortality in our single unit Suhar Hospital, which can be used in other units also in Oman or anywhere. However, continuous monitoring, education, adherence to these implemented evidence-based practice are the key of success. It is not about achievement. It is easy to go to the top of the mountain, but to stay there, it's very difficult. So recommendations, conclusion, the same what I have told you, the late onset infection, CLABSI, it's the big threat for hospitalized neonates in NICU, but again, it's preventable. When there is something that we can prevent, we should work on it. Thank you so much.
For this excellent job, and it's just enlightening us, taking us from the beginning of our journey in the NICU when the first center in Oman opened in 1974 at Khawla Hospital, where in Khawla we didn't have even a ventilator. Is it right, Muhammad? Looking at me, it's Rasul. And now we are really like looking at the quality of work we are providing to our patient. Excellent job. Our next speaker is Dr. Basim Abdul Hadi. He's one of our colleagues at Royal Hospital. He's a neonatologist with an experience of 25 years. He has MBBCH from the Faculty of Medicine at Mansoura Hospital University in Egypt in 1998. And he had been at Royal Hospital from 2008, so it's a long journey with us. He is an OMSP trainer in pediatric and member of quality assurance in the at Royal Hospital in Child Health. He has been a speaker in multiple conferences, and he had a publication, Severe Neonatal Hyperbilirubinemia in the first 24 hours of life in a tertiary hospital at Royal Hospital. Today he's going to share with us their experience in managing, I'll say like more about clinical features, risk factors, and outcome of a neonatal invasive candidiasis. So again, we're talking about infection. Thank you very much, Dr. Haj.
Assalamu alaikum. Thank you so much for the invitation and for the attendance. So in the same context of Dr. Saeed's talk, we'll talk about one study we did in Royal Hospital, in NICU, in Royal Hospital. So it was about neonatal invasive candidiasis, a 20-case study series from tertiary neonatal care unit. So this is the outline of my presentation. So I found that invasive candidiasis, it's known as a well-known cause of morbidity and mortality in NICU. And Candida sepsis became the third most common cause of mortality following Candida sepsis became the third most common cause of late onset sepsis in NICU, following gram-negative bacteria and coagulase-negative staphylococci. And mortality rate is high, and actually in many centers it's variable, 20% in low birth weight, sometimes 30%, and some studies has shown 60% even. And survival can have severe neurodevelopmental impairment. Risk factor is known for invasive candidiasis: low birth weight, prematurity, use of central lines, invasive ventilation, abdominal surgery, exposure to broad spectrum antibiotics, and steroid use. Candida albicans usually is the most common species, and other Candida like Famata, Torbicalis, Barbicillosis are also common, but nowadays becoming more common than albicans. The objective was the study to show the prevalence of risk factors in our NICU at Royal Hospital, and what are the clinical features and outcomes of invasive candidiasis. Methodology, we used a retrospective study, case control. We have examined 20 neonates admitted from period of 2006, January, to December of 2020, 15 years period. These cases were matched with 40 controls. Each case was 2 controls, matched by gestational age, birth weight, and birth date. The isolation of Candida species was from sterile location, means from blood. So babies who had enterocecal tube culture positive or urine culture positive were excluded, only with blood. The data of the cases and controls were taken from our Ashifa system, 3+, taken all provided demographic data, clinical data, lab, and all these important informations. And each episode of infection was from the time of admission till time of discharge or death. Data included gestational age, birth weight, age at infection, central line presence, central line days, invasive ventilation used or not, invasive ventilation days, use of H2 blocker, steroid, type of surgery. The study in total showed 60 infants, 20 cases, and 40 controls. As we mentioned, in 15 years period, we had admission in this period 14,820 neonates admitted to our NICU, and we had these 20 cases, so approximately incidence of 1.3 per 1,000 admissions. The male infants were the predominant group, 75%, and median NICU stay in cases were about 53 days, in comparison to controls with 32 days. This is the table that shows the male predominance in the cases, 15 cases out of 20, 75%, and length of stay, as I mentioned, 53 days for the cases. 75% of the isolated Candida species were Candida albicans, and 65% of infections happened after first week of life, means usually in second and third week. So we have identified multiple several risk factors which already known: young maternal age, presence of central line, invasive mechanical ventilation, TBN, prolonged hospital stay, necrotizing enterocolitis, babies who had abdominal surgery for congenital GI malformation like intestinal obstruction, babies who had cardiac surgery. We had 4 babies who had cardiac surgery. All these have been linked to increased risk of invasive candidiasis. Again, this table shows the central line days, as you show here. In the, it's about like 13 days, significant. Invasive ventilation days, about 18 days, significant also. TBN days, about 20. Duration of H2 blocker use, and the candida colonization before infection. About the long-term outcome, we have found that mortality rate was 45% in our cases, and no death in the control group, and 10% had full recovery, 45% had full recovery, and 10% had sequelae. So this study confirms and highlights the significant risk of invasive candidiasis in NICU, especially males, and extreme low birth weight, infant less than 1 kg. And this infection becomes more after the first week of life, suggesting hospital-acquired infection related to invasive procedures and the prolonged NICU stay and use of central lines. Candida albicans, as we mentioned, becomes the dominant species, although some other non-Candida albicans also found. Morbidity and the mortality of neurodevelopment impairment also remains very high, so despite treatment. For that, we should emphasize on the early identification treatment of such cases. So in conclusion, neonate with risk factors, which is known, should be highly suspected to have invasive candidiasis, particularly if their NICU stay exceeds 1 week. And there was a recommendation from American Society of Infectious Disease to start fluconazole prophylaxis or antifungal prophylaxis for babies less than 1 kg. Fluconazole prophylaxis is very safe and reduces the incidence of invasive candidiasis, and the usual dose regimen is 6 mg per kg twice weekly. For duration, depends on the use of central line and broad spectrum antibiotics also. The risk factor found in our study suggests more infants also can benefit from the antifungal prophylaxis, not only extreme low birth weight infant, but also cases who had additional risk like cardiac cases or surgical cases. So our study turned from just checking the clinical features outcomes to be again quality improvement project, and we started to implement antifungal prophylaxis for our babies since last 3 years, and we didn't have a single candida case. Our study was published this year in May. This is our reference. I want to thank all of you, and I want to thank the co-authors, Dr. Muqtabal Ajmi and Dr. Hilal Hashami and Dr. Minal Rawahi. Thank you so much.
Thank you, Dr. Bassem, for your interesting talk. And Khitam ho misk, I would like to invite Mr. Badr Sawafi. He's a senior laboratory technician at Ibri Hospital. He has worked in Ministry of Health since 2005. From 2005 till 2012, he worked as a lab technologist in various lab sections, including hematology, biochemistry, microbiology, and blood bank. In 2013, he started to act as a section supervisor in biochemistry and hormones. In 2021, till date, he has worked as a general lab supervisor. Badr has active participation in the hospital committee for patient safety and quality program. He's going to talk about enhancing transfusion safety in pediatric thalassemia patients with recurrent adverse reactions using leukocytes-reduced blood transfusion. Please welcome Mr. Badr.
Assalamu alaikum. welcome to the last presentation. Inshallah, it will be on time, inshallah. In this presentation, I will try to summarize our work. Our work in enhancing transfusion safety in pediatric thalassemia patients, especially with those who are suffering from recurrent adverse reaction using leukocyte-reduced red cell transfusions. As you know that blood transfusion is one of the therapeutic procedures. However, it contains some kind of risk in terms of infections, in terms of immune reactions. That's why it is recommended that before we go ahead with a plan of blood transfusion for any patient, we need to assess the risk and benefit for that patient. Unfortunately, there are particular patients who are suffering from inherited anemia. They are frequently exposed to the blood transfusions because it's part of their main treatment. Those patients are actually they may suffer from adverse reactions, which contains hemolytic transfusion reaction, which is very rare actually, but they are suffering from fever, allergy, and sometimes anaphylaxis. For these reasons, we have seen from our KPI in our hospital that the transfusion reaction rate is coming mostly from those patients who are suffer from inherited anemia like thalassemia and sickle. And our data shows that the majority of these patients are coming from the pediatric group. So this is ignite us to see how we can help them and how to reduce some kind of risk from the transfusion itself. So we have decided to start introduce LCR. What do you mean by LCR? It's like whole blood which is removed. WBC has been removed from that unit. In general, we have registered actually in our hospital around 31 thalassemia patients. Out of these 31, there are 19 patients who are from pediatric group. We found that from the 19 patients, which is from the pediatric group, only there are 8 of them are frequently suffering from the adverse reaction after getting transfused. So we have sit together with our team and with our pediatrician team, and also from the expertise from the central blood bank. So we start to introduce LCR. Since that LCR actually was not in our menu for them, so we start to bring them in our in-house facility. This is how the LCR looks like. It's a bit consume timing because we need to prepare the blood. Filtering the blood itself, it will take around 8 hours, and also it's a little bit costly. So it was not that much familiar in all the hospitals. So we have decided only to give such a facility only for those patients who are suffering frequently from adverse transfusion reaction. So after that, we need to investigate the action that we have taken. So we make a study to evaluate the effectiveness of the leukocyte, reduce RBC transfusion, improving transfusion safety, and reducing adverse events in pediatric patients, especially those who are suffering from thalassemia. We are not including everybody, we are including only thalassemia patients. So our methodology or study design, the study enrolled 6 patients who are diagnosed as beta thalassemia major and were included and monitored for 22 months after the episode of reactions. The study also included those who are treated in thalassemia day care clinic and can be monitored in hospital and at home, because we have some of these patients are actually visiting other institute other than every hospital. So only we strict only with those patients who are coming frequently or stick in our hospital to make the monitoring easy for us. Targeting the patient who had transfusion adverse reaction more than one time. The study also includes those who used to receive unfiltered blood with two different additives, CBDA and SAGM. Actually, the selection of our cohort, you can say, is based on the clinical history and based with the discussion with the pediatrician team. Most of the monitored patients are suffering from febrile fever and muscle pain and allergy. So we have decided to monitor all these 6 patients, and we started to shuffle the transfusion action for them from the unfiltered blood to LCR. All the data has been collected from Al-Shifa-based and blood bank, monitoring modules like blood request, blood issues registry, cross-matching, and monitoring of blood transfusions. Post-transfusion reaction incident also has been retrieved to investigate if there is any document for them after changing from unfiltered to filtered one. Major source of data is clinical information with help of assigned physician and assigned staff nurse. This is the result actually for 22 months. What we can see from this Excel sheet, we can say, or table, before we started LCR for our patients, most of these patients actually they have in between from time to time, they are getting mild to severe reaction. Most of these actually non-hemolytic transfusion reaction, which is tend to be actually feverish. We can say febrile hemolytic transfusion, non-hemolytic transfusion. After that, you can see most of them, they are not even getting any episode of transfusion at all. Unless one case. Discussion. In general, leukocyte reduced blood decreased the number of reaction incidents, so the use of leuko reduction filter blood could reduce 84 because we have only noticed only one case after introducing LCR. 84% of adverse reaction among of these patients. 16% has been occasionally has been reported. We can say the number of the patient was only one. Significant reduction of non-hemolytic febrile reaction has been dropped to 0% incidence. No medication is recommended to be given with those leukocyte reduced blood because after using LCR, there is no readmission has happened, no extra medication has been taken because the patient usually they will again return back to the hospital for admission. In conclusion, we can say that over 2022 months, 172 LCR units are transfused for 6 patients of B-Thal. Only 1 unit of LCR failed to avoid unspecific allergic reaction, which is also not a febrile, it's only allergic. So as a conclusion, the use of LCR blood can reduce the risk of complications among the patient and regular transfusion like beta thalassemia and sickler also if you want to use. It is also can help to reduce allergic reactions. Based on many guidelines, the providence of stock of leukocyte-reduced blood in blood bank is required to be used for many indicators. Providence of LCR blood is a major step to improve the quality and safety of transfusion in every hospital, and not only that, it will reduce the burden for the patient and the family because the admission stay in the hospital will be less, and so also the burden for the family will be less. I finished my presentation. Thank you, ma'am.
Thank you very much, Mr. Badr. Now, I think it's a time to have short break, I will say. If you have any questions, we can ask the speakers. ولا جوعانين تبون تتغدون على طول؟ So you bear with us the last inshallah. إذا ما عندكم any أسئلة, no questions, we can proceed for the next. Questions? No questions? No. Okay. So I will leave you for the next session, inshallah.
Thank you, Dr. Saad. Thank you for all our audience today. I know it's lunchtime, so we will inshallah just make it fast, but I think we should give some appreciation for everyone who participated today. Specifically, I would like to thank the poster presenters. They really did a great job presenting very important papers, and I hope you got a chance to visit and learn more about these posters. So we had a panel of evaluating those posters, and we have 3 winners for the poster presenters. So I would like to ask Ms. Asma Al-Hidefi to welcome us to stage to hand over the winners. Of course, everyone did a great job presenting, but there were 3 specific presenters that really stood out, and this is an appreciation from the Quality Assurance Center and all the organizers to give the credit for these initiatives and papers that have been working on. Please welcome. ننتظر بس المصور ياخذ لنا كذا كمين لقطة. We're back. Sorry for the delay. So the poster presentation award for 2025, the bronze winner is Burjil Hospital. Poster presentation award for the silver winner is the Rustaq Hospital. Finally, the poster presentation award, the golden winner is Al Brahimi Hospital. Also like to thank all the poster presentations. Really great work, and we would like to also extend our thanks for them, and I would like to call them to receive their certificates. بنبدأ بالدكتورة مية بنت أحمد بن حمود الشيذانية. الدكتورة مية بنت أحمد بن حمود الشيذانية. الفاضلة مزون بنت سلومة بن عامر المعشنية. الفاضلة ثريا بنت سعيد بن حميد المصلحية. الفاضلة فاطمة بنت علي بن عبد الله البلوشية. الفاضلة ابتسام بنت سعود بن حميد الحاتمية. الفاضل سيري البيني. الفاضلة سوزان بنت محمد بن مانع الخنبشية. الفاضلة ابتسام بنت سالم بن مبارك الرحبية. والفاضلة نجلاء بنت علي بن عامر الهنائية. We would also like to thank the poster evaluators المقيمين على الأوراق العلمية الدكتورة جميلة العبرية. الفاضل الدكتور زكريا العدوي. والدكتورة سفانة السعيدية. طبعا بدورنا نشكر أيضا اللجنة العلمية واللجنة اللوجستية القائمين على هذا المؤتمر اليوم. شكرا جزيلا للجميع لحضوركم، بعضكم بعدهم موجودين فتكرما راح أنادي أساميكم للتكريم. الفاضلة ليلى بنت حمدان بن سالم التميمية. الفاضلة عزيزة بنت خلفان بن سالم العامرية. الفاضلة فرح بنت خالد بن يوسف البلوشية. لا لا معلش. الفاضلة عاتكة بنت عبد الرضا بن محسن اللواتية. الفاضلة نجمة بنت حاجي بن محمد البلوشية. ومن اللجنة اللوجستية الفاضلة حمدة بنت ناصر الوهيبية. الفاضلة سلوى بنت سعيد بن سليمان الهنائية. الفاضل المعتز بن سيف البوسعيدي. الفاضلة أمل بنت عمر بن سالم المحمودية. الفاضلة حنان بنت حماد بن حمدان البيمانية. الفاضلة سهام بن سالم بن محمد الكاسبية. والفاضلة سعاد السابعية. شكرا جميعا على الحضور، نتمنى لكم يوم سعيد وغداء مميز معنا. غرفة الصلاة أيضا موجودة وشرفتونا ونورتونا، وشكرا جزيلا على المشاركة هذه المثمرة. شكرا أخ خميس. شكرا جزيلا.